Hila from developmental pediatrician. And I also welcome Dr. Amit Watkar, who will be joining afterwards. I welcome all the dignitaries who are present now, Dr. Archana Joshi Madam, Dr. Anjali Gokarna Madam, Dr. Vaishali More, Dr. Anuradha Palwankar, who is our secretary. And I request Dr. Leena Srivastav to tell us more about autism and autism, specifically the cognition, IQ, and beyond. That's her topic. Dr. Leena Srivastav, madam. From her busy schedule, she has spared time for us. Thank you so much.
Good afternoon, everybody. It's a pleasure to be here with all of you. And it intrigues me how working in your kind of scenario must be. So I hope one day we can have a tete-a-tete about that. Dr. Jayashree is always such a pleasing personality. It is a pleasure to always interact with her. And thank you for having me here. I think she was very keen on having the cognitive aspect of autism while we speak today. But I am not sure how familiar we are with the regular autism and its screening, etc. So what I've tried to do is first quickly go through the basics so that if there are any junior audience or people who are not very conversant, we can quickly review that before we go on to 2-3 case scenarios where the IQ could play a role in whatever the clinical picture was. I hope that helps, or I hope that was what she had in mind when she asked me to speak about. So she was very keen on the high functioning autism. And I think earlier we spoke a lot about Asperger's and high functioning autism, but I don't know how much of it is really a reality. I'm not saying that children with autism do not have higher IQs, but the thing is that the presentation or their abilities are so scattered that there are some savant skills and some not so savant. म्हणून नेहमीच त्या IQचा ऍप्लिकेशन किंवा फायदा सगळीकडे किंवा रोजच्या आयुष्यात होतोच असं नाही. So I think sometimes limitations come because of that. So if we revise what's autism spectrum disorder, I think now we know, but by the DSM-5, it is an impairment in social communication and interaction with some restricted repetitive patterns of behavior. Now, for those of you who are not conversant, let me review again that when we say impairment in social communication and interaction, it may not always mean language abilities. It may mean just an interactive ability, a nonverbal ability, a friendship or relationship navigating ability, anything that has to do with social interaction or relations. And of course, the restricted and repetitive patterns of behavior also, many times the first thing that comes to our hand, the son is that they're flapping hands. Now, not everybody is going to go around flapping hands. There may be motor stereotypies like flapping hands, spinning around. There may be other repetitive behaviors like speaking repeatedly, whatever, on one topic, repeatedly talking about the same thing. It may be echolalia, repeating what the examiner or we say to the child, or it may be a very, very repetitive or a rigid pattern of behavior in their daily lives. Like many of them would want, the same cup every day, the same yesterday, one child wants to sleep in the same bed and the same, place every day. I don't know how many of you all watch Netflix and Prime, but if the people who watch Big Bang Theory, I think, while I'm watching Sheldon, it's always on my mind. That's a kahi sambandha hota autism shi. So when we're talking about this, we have a very rigid picture in our minds कि there'll be this child जो अजिबात eye contact देत नाहीये, असा बसलाय, अजिबात interact करत नाहीये आणि असा repetitive behaviors दाखवतोय. So I would say that is the end of the spectrum. But being a spectrum disorder, everybody will not be of that level. And you will have typical looking people who may be friends with you and me, but who may have some limitations who would probably fit into the spectrum. So as we said just now, each child is unique and no two children with autism will look the same. As they say, when you see one child with autism, you see only one child with autism. You not see it all because every child will be different. So is it common? Yes, I think it's more than what we had gathered, fathomed, and it is much more common. The recent studies say 1 in 36. Those of you who have been practicing for 2 decades was realize that the figures keep on increasing. Now, let's not go into the details of what we could attribute that to, but अजून पण world over, the mean age of diagnosis still falls into 2.7 to 6 years, which is a pity. कारण इतके वर्ष we are harping about autism, discussing it all the time, आणि diagnosisच उशिरा झाला तर I think we are losing out on many things. So that is something we should always remember. So a quick review of what are the early identifying signs. We know that sometimes even looking at a little infant, जेव्हा तुम्ही vaccine साठी बाळाला बोलवता and you're just interacting with the child while you're filling the injection, giving the injection, and that warm, joyful, you're always speaking to the child and हुंकार वगैरे ते बाळ परत देतंय. ऑफकोर्स आता हल्ली सगळी बाळं वॅक्सिनला पण स्क्रीन घेऊन येतात म्हणून खूपदा ते मिस होतं. पण I think if we remove the screen and the child is playful and we interact with the child, many a times you would find that the absence of this joyful interaction, reciprocation, could obviously awaken you to look at whether these are signs. I'm not saying that's autism. I'm saying that it should always alert you. If the parent says मी इतकी हाका मारते पण तो नेहमी रिस्पॉन्स देतोच असं नाही, मूड असेल तर रिस्पॉन्स देतो, नाही तर नाही. ऑलवेज टेल देम मूड हा 60 वर्षाच्या माणसाची लक्झरी आहे. It is never good. I'm nearing that age, then I'll have the liberty. But it is not a child who is moody. A child always will interact or react or respond when a parent calls him. Most of the time, there's no moodiness associated with a child. Very extremes of temperament, म्हणजे behavioral tantrums which are beyond the typical that we see for that age, and kadi even very bad sleep problems. All these should make you look to see if there are any limitations in the child's social temperament or social behavior or social skills for his age. So it is not always that you have to wait for the classic signs to come up, but even missing these little signs in your clinic while you're interacting with them when they come for the vaccine is good enough. I always think 2-3 simple गोष्टी जे तुम्ही करू शकता. जेव्हा बाळ आत येते तर तुम्ही बाळाच्या नावाने हाक मारू शकता. इवन 1 वर्षाचं बाळ पटकन तुमच्याकडे बघेल, इवन अ यंग वन फॉर दॅट मॅटर. तुम्ही विचारलं आई कुठे आहे, पटकन आईकडे बघेल आणि असं बोटा. पंखा कुठे, पंखा युजली दाखवेल. सो त्या 30 सेकंदात जेव्हा बाळ एंटर करतंय तुमच्या क्लिनिकमध्ये, यू हॅव क्विकली सीन रिस्पॉन्स टू नेम आहे की नाही, जॉईंट अटेन्शन आहे की नाही, पॉइंटिंग आहे की नाही, शेअरिंग आहे की नाही, राईट. आणि मग तुम्ही पटकन अरे ते बघ कोण आला, तो पटकन वळून बघेल. सो दीज 3-4 simple questions will just tell you whether there are any glaring red flags or not in that child's development. आणि मला वाटतं हे सिंपल गोष्टी करायला कधीच हरकत नसते, स्पेशली वेन यू आर सीइंग अ चाइल्ड फॉर द फर्स्ट बूस्टर. 1.5 वर्ष, 2 वर्ष, 2.5 वर्षाच्या वयात. दीज आर व्हेरी सिंपल थिंग्स. आता मी 2-3 अगदी सिंपल गोष्टी इकडे लिहिलेत की 1 वर्षाचं बाळ, जसं आपण म्हटलं नावाला हाक मारली तर तो पटकन बघेल. ही युजली रिस्पॉन्ड टू हिज नेम. युजली 1.5 वर्षाचं बाळ जेव्हा येतं, जरी बोलणं असेल नसेल तरी पॉइंटिंग, गेस्चरिंग, फेशियल एक्सप्रेशन हे पटकन शेअर करेल आणि दाखवेल, राईट. आणि 2 वर्षाचं बाळ, सपोज तुम्ही काहीतरी खेळ दिला, युजली आपण क्लिनिकमध्ये काहीतरी टॉय देतो, he will look up to you and then take the toy. Usually तो एक joint referencing होतोच, right? But a child with features of autism usually तुमच्या खेळाकडे बघेल, खेळ घेईल, उघडायचा प्रयत्न करेल, नाही उघडलं तर आईचा हात घेईल, ते उघडायचा प्रयत्न करेल, all the time without looking at you or the mother. So much is missed in that 1 minute of interaction that you are trying to do while the child walks in. आणि थोडंसं मला वाटतं आपण ओपीडी खेळाबद्दल, मुलं काय खेळतात, आय होप अँड विश की पालघरमध्ये अजून मुलं बाहेर खेळतात. इकडे तर सगळे फक्त कम्प्युटर आणि टीव्ही बघतात. बट देन जर मुलं खेळतात तर ते काय खेळतात, मला नेहमी वाटतं थोडंसं मुलांच्या खेळाचे व्हिडिओ आणा ना. म्हणजे 1-2 गोष्टी जरी तुम्ही पाहिल्या, आय थिंक द प्ले इज सच अन इम्पॉर्टंट ऍस्पेक्ट ऑफ social things and cognitive. Since we are speaking of cognitive, आपलं कॉग्निशन सुरू कधी होतो, ऑब्जेक्ट परमनन्स. म्हणजे जे आपण अगदी 7-8 महिने, 5 ते 8 महिन्याचं बाळ पण पिकबू खेळतो, आपण ता करतो, ते त्याच्यातनच आपल्याला कळतं की त्याला ऑब्जेक्ट परमनन्स आहे. आपण गोष्टी लपवतो, तो शोधून काढतो, परत ऑब्जेक्ट परमनन्स आहे. आपण काहीतरी खेळ देतो, त्याच्याने वाजल्यावर आवाज होतो, तर तो बाळ परत परत करतो. सो सिम्पल थिंग्स in play actually reflect cognition in very younger children. Younger children मध्ये cognition काय असतं? It is just थोडे fine motor skills, थोडे response to instruction skills and थोडं communication skills. So 1.5-2 वर्षात पण आपण ह्या छोट्या गोष्टींकडे लक्ष दिलं तर both autism पण आणि cognitive delays पण आपल्याला spot करता येतं. So it's very important to look for play skills in a child. कारण प्रिटेंड प्ले, भातुकली खेळणं, बाहुली बरोबर खेळणं, खोटं खोटं चहा करून देणं, ऑल दीज थिंग्स आर इमॅजिनेशन, आर ऍबस्ट्रॅक्ट, आर सिम्बॉलिक, अँड दीज थिंग्स रिफ्लेक्ट द चाइल्ड्स कॉग्निशन ऑल्सो अँड सोशल ऑल्सो. सो वाईल दॅट इज मिसिंग अँड द चाइल्ड हॅज व्हेरी रेपिटेटिव्ह पॅटर्न्स, फक्त पझल्स खेळतोय, शेप्स खेळतोय, कलर्सच येतात, चाकं फिरवतोय, देन इट इज मोर ऑफ अ रेपिटेटिव्ह पॅटर्न. सो आय थिंक इफ वी गो बॅक टू आपले जुन्या पद्धती खेळायचे, की आजोबांबरोबर घोडा घोडा खेळतोय, आईला चहा करून देतोय आणि आपण सगळे आपले खोटं खोटं फुंकून फुंकून चहा पितोय घरी आल्यावर. These simple things, I think, were such beautiful things for social and cognitive development. And those, I think, are the things many of these children miss out. One, because they're screwed, screens, like they are so glued to the screen that obviously त्यांना बाकीच्या गोष्टी लक्षात येत नाही. And secondly, of course, because they have some social communication deficits. So symbolic representation, pretend and imaginative play are very, very important things जे आपण आपल्या पेशंटशी बोलू शकतो त्याच्याबद्दल, किंवा अटलिस्ट विचारू शकतो त्याच्याबद्दल. 1.5 वर्षाच्या खालच्या मुलांना, इफ यू नो दॅट इफ 15 to 18 months if they come to you आणि तुम्हाला शंका वाटते, मोस्ट ऑफ यू ऑल मस्ट हॅव डन ECD, तर आपल्याला माहिती आहे that you do MChat, right? And then even if MChat is positive or negative, you would still want to watch this child on follow-up. But if the MChat shows that there is a high or medium risk, definitely you would want to observe the child, give him tips on stimulation, talk to them about communication, and maybe even refer to a center close by if that's available. So MChat is such a simple tool, available online, easily doable, मराठीत पण अवेलेबल आहे ऑनलाईन, आणि अगदी साधं आणि करण्यासारखी गोष्ट आहे, तुमच्यापैकी कोणी करू शकतं. अँड द थिंग इज की खूपदा पेरेंट्स आर नॉट कन्व्हिन्स, एवढं छोटं बाळ, आमचे वडील पण उशिरा बोलले होते, एवढं काय आहे. बट देन इफ यू शो देम दॅट देर इज अ हाय रिस्क फॉर ऑटिझम, तर थोडंसं तरी त्यांना कन्व्हिन्स होतं की काहीतरी करायची गरज आहे. काही नाही तर स्क्रीन बंद करून स्टिम्युलेशन अँड प्ले वाढवलं तरी इट विल मेक अ ह्यूज डिफरन्स टू दॅट चाइल्ड्स आउटकम, राईट? So MChat we have spoken about. Now just a summary of red flags of autism. No babbling or pointing or other gestures by 12 months. No single meaningful words by 16 months. No two-word phrases. आता 2 वर्षात आपण काय एक्सपेक्ट करतो बाळाकडनं? आई दे, बाबा चल. So two-word phrases, but these should be meaningful and purposeful, not epolalic. Chota bheem laddu, that is not what we want him to say. We want him to use purposeful, communicative, phrases. And कुठल्याही एज मध्ये, if you feel that there is loss of language, loss of social skills, which is indicative of some kind of regression, then obviously we would want to at least screen for autism. So these are the simple red flags which I think anybody can put out on his OPD, आणि पेरेंट्स ते वाचून खूपदा आत येऊन तुम्हाला विचारतील. सो बेसिकली जेव्हा आपण ऑटिझम बद्दल बोलतो, असं नाहीये की यू विल सी अ कम्प्लिटली डिफरंट चाइल्ड. दिस इज अ टिपिकल चाइल्ड बट with slightly atypical patterns in his development, and that's what we are looking for. Now before we go ahead, again it is very important to remember what looks like autism but is not autism. कारण ते आपण नाही डिफरन्शिएट केलं तर many a times we would be, many a times we see की cortical visual impairmentचं बाळ, आय कॉन्टॅक्ट नाहीये, थोडे सेन्सरी इश्यूज आहेत म्हणून वर्षानुवर्ष ऑटिझमची थेरपी घेते. सो इट्स व्हेरी इम्पॉर्टंट फॉर अस ॲज डॉक्टर्स that we take up charge and not just the therapist diagnosis नको, आपण डायग्नोस करून, आपण मिमिक्स काढून मग ऑटिझमचं डायग्नोसिस कन्फर्म करायला पाहिजे. सो व्हॉट इज नेव्हर टू बी मिस्ड? एनीबडी, what do you think that you should never miss which can mimic autism? So definitely a hearing loss. What we want to say is definitely you want to do a hearing assessment in every child, right? And I know that it won't be the same. The hearing impaired children will always have better gesture communication or better non-verbal communication, will have better eye contact and so non-verbally with actions, they will be expressing so much that it's only the verbal aspect would be missing. But recently we have seen की काही बाळांना ऑटिझम आणि हिअरिंग इम्पेअरमेंट दोन्ही पण असू शकतं. सो डोंट बी व्हेरी कॉन्फिडंट की याला ऑटिस्टिक फीचर्स आहेत, रेपिटेटिव्ह फीचर्स दिसतात, याला हिअरिंग नसेलच प्रॉब्लेम. सो यू कॅन हॅव बोथ. म्हणून हिअरिंग असेसमेंट करणं आय थिंक इज व्हेरी व्हेरी इम्पॉर्टंट. सेकंड व्हिज्युअल इम्पेअरमेंट, ॲज आय सेड की कॉर्टिकल व्हिज्युअल इम्पेअरमेंटच्या मुलांना कधी कधी खूप सेन्सरी इश्यूज, म्हणजे ते स्विमिंग वगैरे करतात बिकॉज आय थिंक दे लुकिंग फॉर sensory input from outside, and that is why sometimes they may mimic these children, especially if it's accompanied by a global developmental delay. कारण मग त्याच्यामुळे कम्युनिकेशन डिले असू शकतो, कॉग्निटिव्ह डिले असू शकतो, and that time many a times it may mimic autistic features, and that is also something you should always look for. Some near misses, okay, social pragmatic disorder. Now this is like autism, फक्त त्याच्यात repetitive behaviors विशेष नसतात. So this is something you have to, look for, not to be missed. I know there are some neurologists here in the audience, and I'd like to just talk about Landau-Kleffner syndrome. I won't be elaborating, but this is something, even though the regression with the acquired aphasia comes slightly later in age, usually 5 to 7 years. It's not so early as we see children with autism. But still, one thing we would like to remember is खूपदा LKS मध्ये seizures नसतात. So it is not that every time there will be a seizure, then a regression, and then it is LKS. With an abnormal EEG also, we may not see a seizure precipitating the thing. So it is always good to be aware and think about it, especially when the regression is in older ages. Rett syndrome, when there is drastic regression, 6 to 18 months nantar, female child, drastic regression, acquired microcephaly, then you, and of course the loss of purposeful hand movements and the hand wringing or something like that, you definitely may have to think about Rett syndrome, because the whole prognosis will then change. So some blink and miss conditions, because these are conditions we don't think about usually, and that is why we may miss them. So one is a reactive attachment disorder, and this may come when there is a history of severe neglect. Like I've seen this only once, when the mother was very, very depressed and they were in some remote place, आणि मग तिकडून आणलं होतं त्यांना, and the mother was so depressed की लाईटच लावायची नाही, जेवणच करायची नाही. So this child पूर्ण असं कोमजून गेली होती ती मुलगी, आणि that seemed like lack of social interaction, but then it was reactive attachment disorder, because after giving her good nurturing care, the child did do better. But this is something we must remember, especially हल्ली आयांना postpartum depression किंवा depression असेल, आणि small families असल्यामुळे there's not too many people to take over the care of the child. So something we must remember, selective mutism, ज्याच्यात the child is unable to speak in certain social situations. Like शाळेत गेल्यावर चुप आहे, but then if you review videos, घरी बोलतेय, दुसरीकडे बोलतेय, नातेवाईकांकडे बोलतेय. So it is not that every situation, only in select situations the child is anxious and thus refuses to speak. And then obsessive compulsive disorder, कारण autism मध्ये they repetitive patterns of behavior असतात. कधी कधी in older children OCD kind of features will look like ASD features, especially the repetitive ones. So that is something again that we must keep in mind. Always look for the associated etiologies also. खूपदा असं होतं की आपण जनरल एक्झामिनेशन करतच नाही, ऑटिझम आहे म्हणून, the child is just going to intervention, and आपण कधी नीट एक्झामिनच केलं नाहीये. So you miss this really big, huge staring cafe au lait macule. So नेहमी लक्षात ठेवा की tuberous sclerosis, neurofibromatosis, these may be associated conditions, and again that will change the prognosis. So you may have to do MRI and do all that. Epileptic syndromes like West syndrome, almost 30% of West syndrome may have autism to follow up with. So it's very important that West syndrome bara zala tari you follow them up for their development. And of course, genetic syndromes aaplyala mahiti hai, commonest being Fragile X. So now we've seen that it's not, only the autism features ahead. We must look for the mimics, we must evaluate, we must look for associated conditions. And now let's come to the main cognitive things that she spoke about. So we did see that early development madhun पण cognition evolve होत असतं. So we have to focus on those areas much early in life. So let's look at this 2.8-year-old child. Again, very, very prototype, typically came with hyperactivity, came with delayed speech. Typically, जे आपल्याकडे लहान मुलं येतात with features of autism, the birth history was not significant. Developmental history मध्ये, as you will see, fine motor is usually involved. कारण बाळाला तेवढं फोकस नसतं, अटेन्शन नसतं, सिटिंग नसते, एंगेजमेंट नसतं. So, like it or not, most of them do not have age-appropriate fine motor skills. So, fine motor skills was down, communication, both verbal and non-verbal was delayed, and social interaction obviously was not age-appropriate. ADLs, activities of daily living, I think that is something to me, even if you don't have a developmental setup absolutely in your village, but these are some things you can always train the parents to do. कारण अगदी 5 वर्षाचा मुलगा आला अँड बिलीव्ह इट ऑर नॉट डॉक्टर जयश्री, जसं तुम्ही म्हणता हाय फंक्शनिंग किंवा चांगला IQ असेल तरी ऑटिझम आहे म्हणून जेवतो का आपल्या हाताने? नाही, मीच मलाच भरवावं लागतं. व्हॉट इज भरवावं लागतं? तुम्ही भरवता म्हणून तो जेवत नाही, तो उपाशी राहिला की तो जेवेल. सो आय थिंक ऍक्टिव्हिटीज ऑफ डेली लिव्हिंग थोडं आपण कल्चरली पण जास्त इंडल्ज करतो, पण स्पेशल नीड्सच्या मुलांना तर आय थिंक आपण जास्त क्लिवेज देतो अँड वी डोंट मेक देम इंडिपेंडेंट इन देअर ड्रेसिंग, अनड्रेसिंग, ईटिंग अँड ऑल दीज स्किल्स. म्हणजे मी तर म्हणते लॉकडाऊन मध्ये पोळ्या पण माझ्यापेक्षा चांगल्या करत होते काही मुलं, इवन द CP चिल्ड्रन. सो इट्स more about training than about assuming that the child has a problem म्हणून तो काम करणार नाही. का नाही करणार? त्याला इनफॅक्ट मोठं प्रॉब्लेम्स नाहीच आहेत. सो that is something I think all of us should counsel the parents, because I think SQ is much more important than the IQ is. सो ह्या चाइल्डला अजून काय होतं तर जनरल एक्झामिनेशन मध्ये पॉझिटिव्ह फाइंडिंग्स मध्ये फक्त पॅलर होतं, विच अगेन नीड्स टू बी लुक्ड इन टू, बिकॉज iron deficiency can cause a little behavioral issues like irritability, etc. B12 deficiency can cause cognitive problems. So it's always important to look at the basics also, and you can't miss a simple hemogram and a thyroid, especially in any child with developmental issues. Right? Neurological examination मध्ये फक्त mild hypotonia होता है. Let me remind you that many a times children with autism may have mild hypotonia. It doesn't always have to be treated with therapy unless there are some functional implications. बाळाला उडी मारता येत नाहीये, बाळाला काहीतरी करता येत नाही म्हणून थेरपी देणं इज ओके, but just mild hypotonia without any functional limitations need not be treated. Right? On behavioral observation, I think every child with developmental and behavioral problems, the most important part is your observation. And that, of course, keeps on improving with experience. On behavioral observation, you see this child has poor eye contact, inconsistent response to name call. He's not engaging to me, खूप toys deta hai, but then he's only interested in your pen or your chashma. He's not engaging so much. And then there's, of course, some repetitive play with some objects and hand movements. Always, any child with developmental problems, detailed birth development, psychosocial history, because we spoke, whether it is the maternal depression, whether it is family environment, it is very important to look into these things. General and neurological examination, behavioral observations, hearing and vision evaluation, and then you come to the actual development, behavioral and autism assessments, which you may not do in your clinics. You may refer whatever is the process in your town. And then, of course, depending on all the domains that are affected, you will plan an intervention plan. Right? Now, in this child, communication, fine motor, problem solving, personal, social, all were delayed. So problem solving, communication, and fine motor, these are going to contribute to his cognition later. So if you work only on his speech, that's not enough, because these goals will then be left out. He will not be independent in his activities of daily living. And in future cognition, because we've not put inputs at this age, it may get hampered. Okay, so it's very important that even if this child has autism, that is not enough. Knowing कुठल्या areas वर काम करायचे, कुठले domains वर focus करायचं, and any pediatrician knows that. The Nelson, especially the newer versions, give development so beautifully that I think there's nothing that pediatricians don't know about development. We know it better than anybody else. We just don't, believe in ourselves as much as we should. So any young child with autistic features will have limited eye contact, joint attention, finger pointing, little interest in his peers, or even if he has interest, he will not be able to initiate that interaction. He may have limited display of language, or he may have a lot of language, but not great communication skills. And then, of course, sometimes he may get upset with minor changes in routine. But then the other hand, when you see older children, and especially if they are cognitively better, like we're focusing today, they may have difficulty just maintaining conversations. Context lose होतो. Aeroplanes आवडतात तर मध्येच aeroplaneचा topic निघून येतो. They find it difficult to take another's point of view. त्यांचा एवढूसा दुःख तुमच्या एवढ्या मोठ्या calamity पेक्षाही मोठा होतो, because they are unable to register how difficult it is for you. That navigating of relationships is the difficult part for them. And म्हणून friendships एवढे होत नाहीत, किंवा friendships maintain होत नाही, आणि socially appropriate behavior ला कधी कधी problem. Now, having said that, the core features of autism we have spoken about, but what about comorbidities? There's so much a pediatrician can do in his own clinics, especially with the lower ones that I'm speaking about. There may be GI issues, constipation. How do you treat it? You don't need anybody else to treat it. You treat it just like any other constipation child in your clinics. And they do have higher rates of constipation than other children. Sleep issues, how do you treat them? You treat them mostly with sleep hygiene, some behavior, giving the child a routine, stopping screen, and occasionally you may need melatonin for shorter periods. Epilepsy, 30% of these children may have epilepsy, right? But then come to the first two topics, which are the topics which are going to be discussed today. So one is, of course, behavioral issues like hyperactivity, aggression, ADHD, which Hila will speak about in a bit. And the second is intellectual functioning, and 30% of these children may have intellectual impairment. Not all of them, right? So there will be many of them which may have normal intelligence also. Language impairment is also not necessary in all the children. Some may or some may not. So let's come to this case quickly. We have three cases where I can just show you. A 6-year-old came with poor scholastic performance. Standard first मध्ये होता. शाळेत आधी कोविड लॉकडाऊन मध्ये ही डिडंट गो टू स्कूल, तर त्यांना वाटलं शाळेचा एक्सपोजरच नव्हता, म्हणून अकॅडमिक डिफिकल्टीज येत आहेत, त्याला बेसच मिळाला नाही. तो कोविड चाइल्ड आहे. माय गॉड, पेरेंट्सनी हल्ली इतके टर्मिनॉलॉजीज बनवले, कोविड चाइल्ड, कोविड बॉर्न, and everything is attributed to that. But when you go down on history, it is surprising. Even in a city like Pune, we see so many parents have not realized when their child has developmental delay. So if you go down on the history, तुम्ही बघताय की त्यांनी चालणं पण 1.5-2 वर्षात सुरू केलं होतं. फाईन मोटर पण डिले, कम्युनिकेशन, सोशल, सो सगळीकडनं डिले. So it seems more like a global developmental delay. But then तुमचे behavioral observations again, which are very important, and in that you find की थोडं fleeting eye contact पण आहे, interaction एवढं चांगलं नाहीये जेवढं cognitively तो ठीक आहे, आणि repetitive talk इकोलॅलिया आहे. तर तुम्हाला दोन्ही गोष्टी दिसतात, थोडं ग्लोबल डेव्हलपमेंटल डिले पण आणि थोडेसे ऑटिझमचे फीचर्स पण. Now, this is a child, when you do IQ, many a times you will see that he has intellectual impairment. कारण सुरुवातीपासूनच ग्लोबल डेव्हलपमेंटल डिले होता, किंवा लँग्वेज अँड कॉग्निटिव्ह डिले होता, अँड नाव ही इज ऑलरेडी 6 and he's grown up to have intellectual impairment. There will not be any magic that you will be able to do to change the IQ later. But as I again said, the SQ, you can make him more independent. You can give him academic inputs which are age appropriate, and you can manage his behavior that comes with autism, which Hila will speak about, which will again make him better. So all these paraphernalia or the other aspects that are contributing to his functioning can be taken care of, right? Even if you have the intellectual impairment. As I have a lot of fellows telling me, ma'am, ID to hai, iska aage aur kya karenge? But there's so much you can do. You can make them beautiful, especially I think, I don't know, when I have patients from rural places, it's easier to counsel them because their expectations are so realistic. Even if you get them to work with the parents on the farm, it's okay. Even if they make them constructive children at home, doing all the housework, it's okay. And what is stopping them from doing that? So there's a lot you can do to habilitate these children. Now, because this child had global developmental delay along with the ASD features, here doing an etiological workup, whether it is a genetic workup, whether you think the microcap liye MRI karavasa vatte, all these will be more worthwhile than in the regular child with autism. Okay, so as we said, 30% of children with ASD will also have comorbid intellectual disability. Now, second, an 8-year-old child came with a lot of behavioral concerns, which we will be discussing in the next talk. But here, this child had behaviors even at school, even at home. Saggi kade masti karto and खूप complaints येतात. Now here, if you see, birth history was not significant. Here the motor did not have major issues, but fine motor, speech and language पण parents म्हणतात everything was on time. पण लोकांशी कसं बोलायचं त्याला कळत नाही. अनोळखी ओळखी माणसं सगळ्यांशीच तो सेम बोलतो. सो त्याला ते प्रॅग्मॅटिक्स, दॅट इज द सोशल यूज ऑफ लँग्वेज एवढं कळत नाही. फ्रेंडशिप्स आहेत पण तेवढं पटत नाही. त्याला सगळेजणांनी माझ्या मनासारखंच करायला पाहिजे अशी एक रिजिडिटी आहे. नाहीतर त्याचं पटत नाही, सोडून येतो, मग मला नाही करायची याच्याशी मैत्री. सो दोज थिंग्स दे कंप्लेन्ड अबाउट, इवन दो he had fair enough language and cognition for his age. Behavioral observations, again you saw eye contact was not maintained, attention span was not very good, he was very hyperactive, fidgety, आणि socially व्यावहारिक थोडा तो चंटपणा मिसिंग होता. ही डिडंट हॅव दॅट सोशल स्मार्टनेस आपण जे म्हणतो ते, राईट. तो खूप साधी साधी उत्तरं देत होता. लाईक इवन इफ यू आस्क हिम अ सिम्पल क्वेश्चन, अगदी 42-4 वर्षाच्या मुलासारखं उत्तर देतो, इन स्पाइट ऑफ हॅव्हिंग बेटर कॉग्निशन. सो हिअर दिस चाइल्ड, इफ यू सी, तुम्ही नेहमीच सगळं केल्यावर ह्याचा IQ खूप चांगला आला. पण लुक ॲट इट, द वर्बल IQ वॉज ॲव्हरेज, द परफॉर्मन्स IQ, त्यांचे हे सगळे प्रोसेसिंग स्पीड्स अँड परफॉर्मन्स बेस्ड स्किल्स खूप चांगले असतात. And that's why earlier many a times people spoke about high functioning. But the high functioning is in specific areas. So many a times it doesn't help them so much in their general abilities. So, and then look at the SQ, parat low average. In spite of a very good IQ also, त्याची घरची कामं, घराची कामं, दुकानातली कामं तो अजून तेवढा करत नाहीये. So these are areas we need to focus on because this is going to help him. अकॅडमिकली पण त्यांचे स्कॅटर्ड एबिलिटीज असतात, कारण एक्सप्रेशन एवढं चांगलं येत नाही, एसेज लिहिता येत नाही, बिकॉज दे आर अनेबल टू पुट देअर थॉट्स इन टू वर्ड्स as well as he can. And this child also has ADHD, so I'm sure Hila will be covering that, but he will need a lot of management of his behavior, treatment of his ADHD, along with the management of the ASD feature. So म्हणून psychiatric conditions म्हणजे anxiety, OCD हे पण खूप कॉमन असतात as these children grow up, and especially खूपदा cognition average असेल तर त्यांचा पर्स्पेक्टिव्ह, they realize that they are falling back on some things, आणि खूपदा त्याच्यामुळे पण they may have depression or anxiety because they are unable to cope with the social demands. So this child obviously had ADHD and that had to be dealt with. Now what I want to highlight here is, तुम्ही म्हणाल 8 वर्षाचा मुलगा आहे, आधी डायग्नोज नाही झालं, but DSM-5 does say that currently or in past history, if the child meets the diagnosis, then symptoms must be present in early childhood, but they may be diagnosed later कारण social demands आत्ता वाढले. Because his IQ was average, लहानपणी he could do what was expected of him in an academic base. आणि म्हणून आपल्याकडे शाळेत बरं असतं तर बाकी सगळ्या गोष्टी माफ असतात खूपदा, and that is why he may have been missed out. So this is something we must remember. And last case, that there was a 16-year-old girl, तिला आधीपासून mild ASD होता, and they knew it. But as she grew up, there was, teasing in school, bullying in peers, because she was slightly atypical from the usual peers. And adolescence is such a demanding phase of life. And ती थोडी low वाटत होती on her usual visits. So what you must remember is depressive disorders are also common, especially in adolescents with autism, and you must remember to keep your eyes open for them. Now, whether you treat it with judicious use of medication, whether you want to do a head screening in your own clinic, or you want to refer these to a developmental pediatrician or a psychiatrist, is your call. But then definitely along with interventions, these children may need urgent help for the mood. So other things, as we spoke, there can be GI dysfunction, there can be sleep problems, there can be seizures, and these have to be managed as a normal child. Dental health should be looked for because of sensory issues. Many of them may not brush well. There may be pica, there may be iron deficiency that you can look for. There may be malnutrition because they itke selective astat त्यांच्या eating मध्ये. There may be obesity because sometimes they keep on eating and they are not very socially outgoing. So many a times they're just sitting at home and eating. So many a times ते पण होतं की obesity पण होऊ शकते. Now, coming before the end of the talk, I'd just like to say that here we saw that autism has so many features, it has so many comorbidities. So how do you manage it? It's very tough, and for each child, every child may have different things to focus on. कोणाची एक एबिलिटी खूपच डिमांडिंग असेल, कोणाचं बिहेवियर डिमांडिंग असेल, कोणाचं एसक्यू खूप कमी असेल. सो डेफिनेटली वी कांट, आय डोंट नो, पेरेंट्स आर फोकस्ड ऑन द स्पीच अँड द अकॅडमिक पार्ट, राईट? आणि थोडाफार ओटीला गेल्यामुळे दे डू फाईन मोटर ऍक्टिव्हिटीज, बट देन इट बिकम्स लाईक दिस डिस्प्रपोर्शनेट एलिफंट, त्यात फक्त स्पीच खूप वाढतं, अकॅडमिक स्किल्स खूप वाढतात, बट देन बाकीच्यांचं काय? ते आपली कामं करू शकत नाही, ते फ्रेंडशिप्स करू शकत नाही, दे आर सो बॅडली बिहेव की पेरेंट्स त्यांना असं धरून धरून ओपीडीत आणून असं खुर्चीला बसवून ठेवतात. सो when we are working, we can't focus on only 2 or 3 goals. As a pediatrician, wherever you are, especially if you're in a remoter place, I think it's more important that you remember that many of these aspects you can advise parents on, but see to it that the whole elephant grows. Only then the child is really going to be functional in society. And that is why it's not about the multidisciplinary team, it is about having them in tandem and working on the whole child, not on 1 or 2 areas of the child's development. And I would like to end with these things, that you need to individualize the plan. You need to remember the domains of development as you learn from your Nelson. And of course, you must read up a little to know which are the evidence-based practices so that you can guide parents on that. So I would end with this take-home message, because I think my time is just getting over, that autism spectrum disorder is a single diagnostic category, but there is a lot of individual variability, right? All children will have limitations, mainly in their interaction. Language may or may not be impaired. Problem behaviors and the comorbidities contribute a lot to the child's management, and that is why they should be looked at, even the medical comorbidities. Constipation ni पण बाळाचा behavior absolutely for a toss जाऊ शकतो. In fact, मला जर आई वडिलांनी मेसेज केला की 2 दिवसापासून खूप त्रास देतोय, I first ask them, medically check करा, constipated आहे का, and 90% of the time that will be the cause for change in behavior. So it's very important to look at the simple comorbidities which you can in your own clinics. Any change in symptoms or the course or poor prognosis should make you review diagnosis बरोबर आहे का, काही मिस करतोय का, काही नवीन कोमॉर्बिडिटी आहे का, सीजर सारखं हिस्ट्री वाटते का, व्हिडिओजची गरज आहे का, to review what the child is doing at home. A proper assessment of the problem with all the contributing factors will help you make developmentally appropriate goals. If you have a developmental pediatrics team in your town, in your area, or in your vicinity, that's great. But as a pediatrician, monitoring the child's development is absolutely doable, and management of the comorbidity, especially the medical ones, will help the child and the whole family. So these are some things I think you can read up. The statement of the IAP for autism. There is an American Academy of Pediatrics guidelines also. And then there is a global developmental delay Indian pediatrics guidelines also, all which are very helpful. And I always end, this is one of my favorite quotes. And, when we are working with families, we don't realize how hard these families are working. Sometimes we shout at them, इतना कम काम क्यों कर रहे हो, you don't realize क्या वगैरह. But then one moment we should step into their toes and walk the life I'm living. And if you get as far as I am, just maybe you will see how strong I really am. And I hope we treat our children with autism and their families with empathy, because I think the theme for this year is that they should not just survive, they should thrive. And that will happen only with acceptance, awareness, and appreciation. So thank you very much.
So nice.
छान बोलले, खूप छान.
All three A's we will remember. And
Yes.
also SQ is more important than IQ. That's also very important point you have noted. We have noted we will be doing some medical test and all. Dr. Leena, we have a question from Dr. Vaishali More. Dr. Vaishali, you can unmute and ask.
Thank you, Dr. Leena. That was an excellent talk. Really appreciated it. From a nephrology point of view, I wanted to ask you whether you see renal involvement in your autism OPD, especially nephrotic syndrome.
Right. So I wouldn't know whether statistically significant. I do have, percentage of children who are, dealing with renal problems as well as autism. Uh, but I don't know whether it is more than the other problems that we are seeing them with. So
Okay.
I
Not a
don't,
significant amount.
no, I don't think so. Though,
Okay.
in fact, maybe I can ask you that question. Do you see a significant
I
number of
have
children in your
some, but they are a spectrum of neurodevelopmental, like the way you said in your talk. Like one has a low IQ, but he has autism features also. There's another one who is actually on full treatment at Nair Hospital OPD. So I have like, 4 or 5 patients. It's almost like a series, but each of them is going to a different developmental pediatrician, and each of them has, one has dyslexia with the mother claims that it is dyslexia. I have not seen those papers, but then she does have, that child also had speech delay. He does not have eye contact. He just keeps running around in the OPD, kind of, he doesn't sit in one place. So that is why I was asking you, and all of them are nephrotics, and in fact, 3 of them are on second line treatment also.
So
So,
I somehow have a steady flow of patients coming from nephrologists. So
okay,
even sometimes I wonder whether we should look
there
for
could be a
an
relationship.
association. But not all of them are syndromic. So there are very scattered clinical presentation, like you said. Some are
Yeah,
syndromic, some are not. But
yeah.
then yes, I do notice that my reference from I have 2, 3 nephrologists who are very regular in the referrals. So either they are very good with their clinical pickup, or there is a clinical association. It would be interesting to read up more and see. Thank you for that
Yeah,
question,
yeah.
and maybe we should stay in touch for this.
Sure. Thank you.
Thank you, sir.
Thank you. Thank you,
Dr.
Jayashree.
Leena, can I ask a question?
Sir, please.
Yeah,
Yeah,
I want
Dr.
to ask you
Wasim
whether these, yeah,
is
ma'am, I want
our
to ask you whether
coordinator
these,
today. Yeah.
yeah, sorry for the delay, ma'am. Yeah,
Oh,
I
no.
want to ask you, ma'am, whether these children are, should we adapt them in our regular schools or special schools are better managed for them? What is your take on that?
So probably my take 10 years ago and now has changed a bit because I've become more realistic in my approach. But I wouldn't say that I have a uniform rule. Like as I showed you, we do IQ and the academic performance and the other behavioral repertoire before we make a decision. Now, the ones with regular normal IQs, definitely I would want them in normal schools because I wouldn't want them bored or subject to repetitive goals in a special school. So goes without saying that a regular IQ one, we should manage the other comorbidities that are interfering with him being adapted to a normal school. So I tell the parents that keep in touch with the teachers, and whatever, like suppose it's behavior, like we saw that child with ADHD, then you manage the ADHD. You look for a school with a smaller strength so that he's adapted. Worst come worst, you may have a resource room when the behavior is too bad, he's taken away from the classroom for a bit, etc. These things may be done, but definitely a regular school. Now, the children with autism and intellectual impairment, earlier I was very, very dogmatic that they should be normal schools because they deserve a stimulating environment. But many a times I have realized it doesn't always work well for the child as well, because the goals in the class are not functionally relevant to him. So practically he's sitting in a classroom where nothing that is being taught is of his level. So those times we may have to sort of customize the school choices. But then again, we have a lot of children from remote areas where there are no good special schools. So then again, the ones that are, they have very, very severe IDs, and then this child is out of place in those schools. Now, in those, sometimes I reach a midpoint and I tell the parents that maybe half day they can send the child to a school so that he gets used to structure, sitting, the social skills that we need to teach a child, he learns. And in the afternoon, have a one-to-one remediation for him so that he gets inputs that are more customized to his own level, right? Because if he loses the whole day in school, by evening he's too tired to actually sit down and have his own goals. So I can't say I'm doing the best, but these are things I work out, and I think each of us have to work out the best based on the child, the environment, the place he stays in, how accommodating the schools are. I always think that there is this one teacher which can shape your life also, and our children with autism also. because sometimes I have, such a bad microcephalic 39 centimeters head circumference cerebral palsy child, and there is this teacher who's doing magic. She's really working so hard for him. So customizing, individualizing. I don't think there's one answer to your question, but thank you
Yeah.
so much for
One
bringing
more question I would like to ask you was when you say screen timing, is there any difference of TV screening and mobile screening differences? Because in when we were children, we have seen a lot of televisions, and I think the issue was lesser. So, is there a difference of TV screening and mobile screening? Is there any difference of that?
I don't think we have any studies differentiating that. But may I answer your question into while you say that we watched a lot of TV when we were younger, but
Yeah.
I wouldn't say that because we had the horrible black and white Doordarshan with Amchi Mati, Amchi Mansa. Beyond that, there was nothing on TV. But every child in this generation also who watches TV obviously doesn't land up with autism. So, having said that, screen time is one of the risk factors, but of course, it's multifactorial and there must be so many other genetic and environmental risk factors. But I don't think there's any difference in screen, as you mentioned, because I don't think there have been any specific studies for that. And I think almost all the children are watching screen, but not all of them are thankfully getting autism. So it is a risk factor. One recent Japanese study had said that especially in the first 2-3 years of life, toddlerhood, the screen time has a bigger impact and it increases the risk to twofold. But that's
I wanted to know
I had a
specifically
question.
TV or mobile, what do you feel is more dangerous? I think mobile, I think the radiations, you feel so?
I also think the repetitive content on the screen, because the children just keep on, like when they enter the room only, I can see you've not yet stopped screen and the parents are amazed how I know. But you don't have to think too much. They'll be talking that same content again and again. So I don't know about the rays and how much that, because I don't think we have any studies. So it would be preposterous of me to say anything. But for me, it is under 2 years, no screen means absolutely no screen. I go to the extent of telling parents, choose the screen or me. You have only one choice.
Can I ask you one more question, ma'am?
Yes,
Do you think the adulteration of food now with the chemicals and all that has got something to do with autism? Has it increased? Everything now is more adulterated with hormones and chemicals and all that. So, do you think that has got something to do with autism? Has it increased now?
so again, speaking that the way the prevalence has increased, there must be multiple things. Again, it may not be right of me to be in a position to judge what are the factors. Parents have all sorts of theories, but I really don't know. But then lots of scope for research in this then, I think. But I can't answer your question in a yes or a no.
One last question, ma'am. In the past, in the West also, they have autism. They are related very highly to the MMR vaccine in the West. Though all the bodies have said no, it is cleared, but still, what is your take? Do you feel that it does affect, or should the autistic children, should we give them MMR? What is your take on that?
So years ago, I think more than almost 2 decades ago, when I was new in practice and I had these questions in my mind, I was not sure. And there was this parent from the US who came and they had not vaccinated the younger child and not given them vaccines because they had this theory about MMR. They had the theory about multiple, vaccines and etc. But they didn't give the younger child MMR, but the younger child also had autism like the older child. So I know this is a one-off thing that I'm speaking about, but I think the best we can is believe the studies that do say that there is no connection between vaccines and autism. Probably why the thought could have come up is that we see that the little regression that we do see in the children happens around the same time, around 15, 18 months to 2 years. And probably that is the time that is the vaccine that was being given. So I don't know if that was the association that made parents believe that. But to the best of my knowledge, even by the most recent studies, there is no association. So I will just believe that. I'm a very rigid person that way.
Doctor, yeah. Dr. Anjali and Dr. Shailesh wants to ask question.
Very
Please.
quick comments because we, I think, already running behind time. So, Dr. Lina, I want to tell you that New Horizons has started a center in Palghar district, and we have Dr. Hila coming every week to Vasai, and Dr. Samir Dalwai coming twice a month. So
Wonderful.
we have
Now you have services at your doorstep.
at our doorstep. So we do have a neurodevelopment center close by.
Perfect.
Dr. Shailesh,
Yeah,
he wants
mine
to
is a
ask.
comment rather than a question.
Thanks.
10 years back, the autism spectrum and ADHD, the scenario was totally different. Now the scenario is totally different. People are getting aware, and more number of children either are presenting now recently or they have been diagnosed recently in a better way. Two, three things I wanted to mention about it. The awareness amongst the pediatrician. Still, pediatrician at the age of 3.5 years, when the child is not talking, they say that wo bolega. So, how can we increase the awareness among ourselves rather than blaming the parents for them? That is one. Second thing, a developmental pediatrician at particular center and a developmental pediatrician at different center and the developmental pediatrician at the third centers have different goals in mind. And when the patient goes over here, gets a different opinion and the different line of management the patient goes to. We cater a lot of patients. That's why I'm talking about in a practical way. The patient goes to second pediatrician and they are goal oriented. The third pediatrician writes some medicine to calm them down, and then the therapists are totally different. Some of them are goal oriented, some of them are just putting the blocks red and yellow and then green. And out of 6 months of therapy or 1 year of therapy, the patient is either the patient is the same, the relatives are confused, they are tired, they have spent a lot of money, and almost you get 20% of the result. Out of spending 100 rupees, they get 20 rupees profit out of them, and they really wonder whether are we going on the right track. Yeah, I know that the autism is a long term basis, long term goals are there, but now there were so many less developmental pediatrician 10 years back, 5 years back, 2 years back. In last 2 years, I have seen so many developmental pediatricians from the fellowship program, from the DNB program, from the now the more graduation program are coming up. Can we come up with some standard where we can follow this rule of thumb that these are the things where these are the demarcating market at 1 year? See the NCRT program, what the IAP has come out, they're superb booklets. They have got everything into it. But I don't think any of my pediatrician friends have read that book completely. Yeah, that's I have not also read completely, so I can't blame anybody else for that. So can we do something about it? Can we structure a program for a particular pediatrician? Or these are the things. Can we do something about the parents? Can we do something about the developmental pediatrician? I really don't know what we are doing. I'm sorry for that, but that is the fact what I have seen in last couple of 4 or 5 years. We are being seeing lot of patients and they are going here and there, but nothing coming out of it.
I think it's a very serious thing that you have said, and I think most of us share your concerns. While I think in a field which is as ambiguous as developmental behavioral pediatrics, getting a standard protocol in place in a country like ours is a tough call. But I understand your sincere request, and I hope I am the chairperson of the chapter this year.
Great.
I will put this forward, and I hope we've been thinking about this for a long time, but it is very different. You know, see, in the US, even hospitals have protocols, whether it's antibiotic protocols, whether it's other protocols. In India, getting protocols in place and making people follow them is a challenge. And developmental behavioral pediatrics, there's so much variation in every child that getting a standard protocol to work is very, very tough. But sir, I listened to you with absolutely earnest attention, and
It's
I
a very,
will
very
put this ahead and see if we can one day do something about
Madam,
this. It will be a tough call,
one
but
child,
it's worth
one
it.
child spends 4 to 5,000 rupees
I
per
agree.
month.
I
My
agree.
area, the parent earns 15 to 20,000 rupees, and it's very difficult for
I
me to
agree.
continue the treatment beyond
I
6 months if I can't show them the results.
agree.
And
One,
this is at the picking up of autism at earliest of 1 year 3 months and 1 year 6 months, and at 2 years I'm getting the same response as not picked up the autism.
Meanwhile, one little request that I can, make is that keeping a little diary with the parent and just दर डोमेनचे थोडे थोडे गोल्स वयाप्रमाणे तुम्ही पण त्यांना गाईड केले आणि ते कुठे थेरपी घेतात त्यांच्याकडनं इफ सो दॅट इफ दे आर डुईंग ओनली शेप्स अँड कलर्स अँड अल्फाबेट्स विच आय कीप टेलिंग पेरेंट्स मला पण 2 वर्षात येत नव्हतं आणि माझ्या आयुष्याचं काय बरंच झालं तसं काय वाईट झालंच नाहीये सो आय डोंट नो वाय चिल्ड्रन should know alphabets, colors, and numbers at 2 years of age. So even if the goals are wrong, you can have the, this one to pick up the phone and tell them ki apan ह्या गोष्टींवर काम करू ना. Nelson तर देतोय normal development. So what I mean to say is that if you feel that, there's nobody who is, guiding the child in the right way, or if there are no services, or if there are therapists who are doing goals that are not what you would expect for that age, while I understand your concern and that is a different big goal altogether.
Last 1 year, what we have started doing is, I have talked, Samir is a good friend of mine. I have talked with Samir, and what we have started doing is explaining the parent about it, that what is the emergency, that child should not harm himself. So how to make him run away from fire or from the height, at least teach them who are the neighbor ones, take them to the relatives, and at least start doing that thing, so that nobody teaches in occupational therapy.
I agree.
So at least we can come out with some instruction.
Sorry, sir, please.
If we are coming out some instruction for pediatrician, why not we come out with some instruction to all the occupational therapists, and each center have got their own occupational 3344 in each area. So if we can come together and take some CMEs for them and teach them, then that will be a better system or better outcome we can expect. What we expect from them, if we make them understand, I think that can solve the problem. Some occupational therapies are excellently good.
That's a great.
Some occupational therapies are excellently good, but some occupational therapists are rotten. I'm telling you, rotten is a word I have to use. I'm sorry for that, but they are really bad. So I really think that there has to be some guideline about occupational therapist also. You are the president, so.
No. In fact, Samir is, of course, an integral part and our advisor in the chapter. So I think we should all have a meeting, point taken, definitely. But meanwhile, I think as pediatricians, if we keep an overview of the holistic goals, it will help more instead of one therapy helping the child. I don't know why parents have the belief that speech therapy and occupational therapy will cure autism, and they forget the basic play. बाळाला खेळायला वेळच नाही 4 तास थेरपीच करतोय बाळाला आपल्या हाताने जेवायला वेळच नाहीये तो शेप्सच करतोय सो आय थिंक दॅट इज तो बेसिकली ऍब्सोल्युटली आउट ऑफ लाईन फ्रॉम व्हॉट वी वॉन्ट आवर चाइल्ड टू डू आय टेल देम त्याला जर कलर्स येऊन तो 4 वर्षात कलर्स बोलला आणि स्वतःच्या हाताने जेवायला येत नसेल आणि आई बाबा म्हणायला येत नसेल व्हॉट इज द होल पॉइंट सो I think somewhere we need to change our belief that 1 or 2 therapies are going to, cure autism. So, what we guide our parents is also going to help. So, if there is, like, Dr. Anjali told us that now New Horizons is there, that's great. And in areas where there's nobody, you are there. So, I think it's, I tried my best to explain that, and that elephant was the best I could make by showing that, 1-2 parts were come karuna, you need the whole child to grow. So, but thank you, sir, for speaking so sincerely on the topic. Point taken.
Thank you, sir.
Thank you, doctor.
There was another question regarding sleep in autism. Like all autistic children have some type of sleep disorder, and as such, sleep deprivation may cause cognitive difficulty.
Behavioral problems as well.
So
yes.
is it like cause and effect, a vice versa, or that is the main cause for further deterioration in children?
So I think almost 50 to 80% or something of children with autism will have comorbid sleep problems. So one study had actually said that lack of expectations from parents remains one of the biggest reasons. because most parents will tell me 2 बजे तक उसको उसके साथ खेलते हैं, फिर उसको 1:30 बजे गाडी में घुमने जाता है म्हणून आम्ही फिरायला नेतो त्याला आणि मग घरी येतो. I always tell them, if the sibling or the normal child asks you for these same vague demands, would you fulfill them? तर ते नाही म्हणतात. मग जस्ट बिकॉज ह्या मुलाला आय थिंक थोडंसं आपणच त्या ऑटिझमला एक बुवा करून ठेवलाय, म्हणजे everything is allowed for that child because he has autism. Why would you want to enforce such habits in a child at 2 o'clock in the morning? You would want the child to sleep just like the other children. So thoda-sa, I think it is about sleep hygiene, which all of us know as pediatricians. Thoda-sa, there are some studies which say ki thoda melatonin regulation पण थोडा वेगळा असतो. So melatonin does play a role in children with autism, and so that is why sometimes melatonin helps these children, but nothing helps like behavioral interventions and sleep hygiene. And we've just done a study, we're waiting for the results, but I think it's a mix of all. I don't think we can outline one thing that defines it, but definitely. Sir, please.
Why can't we start Indian Autism Society, and we publish our web page, and we clear all doubts about autism on that page, and we make members of the parents in that, and we tell them how their children have done well. Because now new thing has come up in autism since last 6 months. I am seeing that every kid of autistic parents wants to put their child into swimming pool. So it's
But
really
I think
difficult.
त्यांचे WhatsApp groups इतके strong आहेत ना. If one child does one thing, everybody. I think during
Absolutely,
the
means I am
lockdown it
telling
was
you.
camel's milk. I don't know where India got so much camel's milk, but everybody was drinking.
Yeah, absolutely, means it is very difficult to convince them. So if there is some concrete thing on some website that these are the information, these are there, and they are authenticated information from our developmental pediatrician who have come together and published one particular thing, then at least people will follow that in particular.
We must seriously think about what the options are.
Because the numbers are rising definitely very high.
Absolutely.
They are very, very alarming numbers. And if we see that, then almost another 10-15 years, our 10% population will be autistic or more than that.
Yeah, at Bharati Vidyapit, we see a lot of rural children, so I can absolutely understand that.
Madam, out of 100
facilities in some places, absolutely,
out of 100 patients, there are 3 new autistic patients in OPD.
Yes.
We have 5 more speakers.
Yeah, sorry,
Dr. Hemant Joshi wants,
Dr.
Dr. Hemant Joshi sir wants to talk. Yeah.
प्रेसिडेंट बाई, तुम्ही छान बोलल्यात. मला 70 वर्षात पहिल्यांदा ऑटिझम कळलं.
Sir, please.
ऑटिझमची व्याख्या कट्टी अशी आहे, कट्टी. तो मुलगा कट्टी असतो. सो इट क्रॉसेस एज.
मूड असेल तेव्हा कट्टी असतो, गरज असेल तेव्हा नसतो.
हा, दॅट इज ओके.
सो नीड बेस्ड त्यांचं इंटरॅक्शन.
पण इज मेनी टाइम्स इज कट्टी. सो ही हॅज ऑटिझम. सिंपल आहे, म्हणजे कुणाला पण कळेल. ऑटिझमचा सगळ्यात मोठा आजार इंग्रजीमध्ये बोलतात हा आहे. त्यामुळे the more learned the speaker is, more complicated he speaks, and we don't understand anything. And they don't understand that we don't understand. And we also don't understand. So तुम्ही चांगला बोलल्या, नंबर 1. नंबर 2, ग्लोबल मेडिकल एज्युकेशन खराब आहे, कारण वेस्टर्न टेक्स्टबुक खूप कठीण इंग्रजीत लिहिलेले आहेत. तर आपण सगळं आपल्या सोप्या इंग्रजीत लिहायला पाहिजे आणि सगळे आपल्या भाषेत करायला पाहिजे. म्हणजे आपला IQ जर 100च्या वर असेल तर हे सगळं मराठीत सांगायला केवढं सोपं आहे. सगळे टॉपिक सांगितले की त्याचे व्हिडिओ होतील, पुस्तकं होतील, तयार होऊन जाईल ना, मग तरच जग कळेल. ऑटिझम हे आई बाबाला कळलं पाहिजे, तर ते आपल्याला 1600 भाषेत करायला पाहिजे. तर वी हॅव नॅनो व्हिजन, 5 पेशंट्स, 3 पेशंट्स. तर मोठी फुटप्रिंट करूया आपण. विल डू इट. थँक्यू फॉर लिसनिंग.
थँक्यू ऑल सो मच फॉर दोज इन्स्पायरिंग सजेशन्स. मला एकदम कामाला लागावं असं वाटतं. थँक्यू सो मच.
छान बोलली, छान.
Thank you, Dr. Jayashree.
Because of your talk, we are now more curious to learn about autism. Thank you so much. Thank you, Dr. Leena.
Thank you, Leena ma'am. It was an informative talk, and we'll move to our second speaker, Dr. Hela, who will brief us on behavioral problems and autism. Dr. Hela, are you ready with the?
Yes, sir, I am.
Yeah.
I'll just share my screen.
Thank you. Thank you, ma'am.
Thank you, sir. Is my screen visible?
Yes, ma'am. Yes, please go ahead, ma'am.
Thank you, sir. Thank you for the introduction, ma'am and sir. I would like to thank IIP Palghar and the esteemed office bearers, Dr. Anuradha Palwankar, ma'am, Dr. Alka Badbade, and also very grateful to Dr. Anjali Gokaran, ma'am, Archana Joshi, ma'am, and sir, Leena Srivastav, ma'am, for always inspiring us. With that, I would like to begin my talk with a quote. The children who need the most love will ask for it in the most unloving ways. So this actually pertains to the topic that we have for today, behavioral concerns in autism. So all those challenging behaviors that we may encounter in the OPDs and parents encounter with their children is just that, we need to understand where they're coming from and how we can help get that better. So first, as we are aware, what is autism? So autism is a condition, a condition where the child fails to connect or interact or engage meaningfully with others, and this is there since birth. Now, since he cannot connect or interact right at the beginning, he does not learn how humans behave. So as we understand that autism, the main concern or the main dysfunction is in the first step of development, that is the social interaction, the human connect or the human awareness, as we may call it. Once the interaction gets perfected, and once the child is aware of the parents being around initially, and then step by step, as the child gets more exposure, the child gets more comfortable with relatives, with family, friends. Going ahead, the child is encountered with strangers. Then the child again encounters older children, and finally children his age when the child starts school. So this human connect is the main causative dysfunction in autism, due to which, because the child is unaware of people around, the child usually fails to pick up appropriate social behaviors. So the child fails to see that the mother is brushing her teeth or taking a bath, or we need to wear clothes, we need to eat food in a particular way, toilet training. So all these concerns, usually erupt because there's a lack of social behavioral understanding for the child. Once this gets perfected, then comes the third step of development, what we usually call the communication step. So that again is divided into the non-verbal communication and the verbal communication. As we are aware, the child's non-verbal communication gets perfected first, after which the child's verbal communication picks up. So of course, when the child starts dragging, the parent or the caregiver to the site of what or where it wants things, then joint attention develops, then comes the pointing, then comes the understanding or the reception to non-verbal cues. So for example, when the parent just says bye, or when the parent is just smiling aloud, that's the time the child understands what the parent is trying to express in a non-verbal way. And once this level is reached, the child becomes even more, the maturity of the brain gets better, and then the child becomes more capable to then understand and express the non-verbal communication. So the child himself would start expressing his cues or expressing himself through non-verbally. So that will be, again, the child would point out or would use gestures himself to communicate needs. And after which the child starts developing meaningful verbal communication. So once these levels are perfected, then a child usually goes on to the next step, that is of academics, reading, writing. So this is the New Horizons social behavior and communication sequence that we have devised at our center, which consists of all these 5 steps of development, step by step. So it is pivotal to see that each domain has to be perfected before the child reaches the next domain. So only when the selective human engagement or the social interaction, as we may call it, is perfected and 100%, that enables the child to move further in the domain of social behaviors, and so on and so forth. Now, when we talk about behavioral challenges in children, we can start with some simple common symptoms that we may encounter in the OPDs or we may encounter with children specifically, of autism. So when, my parent mentions that the child has poor response to name call or a poor eye contact that you may, encounter, we need to, look back and see where in the developmental domain, particularly, this child could be. So these symptoms particularly could be a result and maybe a result of this poor social interaction. Similarly, we have common concerns and challenges, represented to us in the form of hyperactivity. Now, here, what we need to understand that hyperactivity for this autistic child is not really the hyperactive wherein there is a lot of energy or a lot of impulsivity, how we see usually in ADHD children. It is basically a lack of understanding of these appropriate social behaviors because of the lack of human connect. The child merely fails to understand what he is supposed to do where. So, for example, if in an office, if the parents are sitting and talking with the pediatrician, the child doesn't understand that what it is supposed to do here. He is supposed to sit and interact with everybody. Or for a matter of fact, if the child is taken to a playground, the child cannot be quiet out there. He needs to run around and do the tasks that the peers are doing. So this is again a lack of understanding of social behaviors that most often is perceived as hyperactivity, as we call it, a very common behavioral challenge that we see in autism. So going ahead, what we need to also understand is that when the first step of social interaction goes wrong, when there is a dysfunction in the first step, the preliminary step after birth, the child is not drawn towards humans and fails to connect to humans, because of which he is more inclined towards objects. So he is more drawn towards objects and things. As we are aware that objects are arranged in patterns like numbers, alphabets, shapes, music, some rhymes, while human behaviors are basically varied. So basically every human will react differently when subjected to in a different social setting or with a different person. For example, the same person would be different with the spouse, would be different with a friend he meets on the way, and would also be different with, for example, a parent, his or her parent. So how humans change themselves with respect to their surroundings and settings. Similarly, as we are aware, objects lack that change or lack that adaptability, and they are arranged in fixed definitive patterns. And because of which the restricted repetitive behaviors, what we most commonly call as stereotypies or the RRBs commonly, they come up when a child commonly is one of the symptoms of autism. So again, the RRBs is really the symptom where, because the human connect is lacking and the child is picking up these behaviors through objects, the RRBs develop. So echolalia, most commonly that we see, a child is actually picking up speech, hearing the opposite person and probably just saying the same thing repeatedly, or he might have heard something long time back, maybe 5 or 6 years back, and he's again remembering that and replicating the same. Or it could be just random vocalizations or random sounds or some new behaviors that the child has picked up. So all these again restricted repetitive behaviors are again one of the symptoms, again a common behavioral challenge that we see. And this is how we need to understand that where in the development tract, where in the trajectory, what has gone wrong and because of which these behaviors are occurring. So these are the common symptoms that we see. Going ahead to the other common behavioral problems that we usually see are the restlessness and the hyperactivity. As I mentioned, where in that tract, what was going wrong and why was that perceived as hyperactivity. Similarly, stimming, that's rocking, body rocking behaviors, tapping, it can be flapping. For some children, it can be spinning or just running to and fro. Innumerable sorts of patterns that the child can pick up. And these all are actually RRBs that the child has picked up from his environment and what the child has actually learned. These are the learned negative behaviors. Similarly, repeating words or phrases, what we call as echolalia. Coming ahead, we have these self-injurious behaviors that we commonly see with children, especially children with older children who come to us with autism and who have probably been on, long-standing therapies and, again, high dose of medication still going on. And irrespectively, the child still has these behaviors, terrible temper tantrums when demands are not met. And the child would just, loosen up his body and lie flat on the floor, crying for hours and hours. Similarly, aggression, biting. So all these are, behavioral challenges that we ought to, identify and pick up. Similarly, there are other concerns as well, wherein the child would be aversive to loud sounds. So the parent usually would, tell you that the child was averse to sounds like the cooker, the mixer, the grinder, or any loud sounds that he heard outside. Or the child would also pull away from being touched lightly, or would only want to, touch people around. So all these are again, tactile issues and concerns, which, again form a part of the behavioral challenges in a child with autism. Similarly, we have eating concerns, which is again very, very commonly seen. So a child can, usually be a picky eater, child having fixed food preferences, only eating matched foods, tending to swallow foods, not eating the solid foods. He would instead eat chocolate. He would instead eat wafers. So there is no medical issue as such, so that we can rule out accordingly. But if given, homemade food, he would be averse to it. Similarly, the child could avoid eating foods of certain textures, or avoid eating foods with certain, with having a little messy textures. So all these could be, concerns that, could help us pick up, these concerns additionally. Similarly, we have, concerns like pica, constipation. Again, constipation, a very, very common problem that we must rule out, and which is, which can cause a lot of behavioral challenges in the child. Again, there could be some forms of epilepsy, and if there is a concern that the child has been irrelevantly crying, and if this is an acute incident that has happened, and again, we must definitely get a sleep deprived EEG done in that case if the concerns persist, and rule out some kind of epilepsy that could have been there as well underlying. Similarly, very, very important, sleep concerns. So as we commonly see, sleep disorders are something that we most commonly find in children. So it could be varied issues like difficulty initiating sleep, or frequent nighttime awakenings, or again, erratic sleep cycle, erratic sleep hygiene, and things go for a toss. We've had parents coming into us who have actually not slept themselves for the last 2 to 3 years well, and because of which the behaviors of the child is on the rise, and parents are so stressed out. So, and this forms a vicious cycle again. So sleep concerns definitely is on top of the cards, and we must make sure that these concerns are alleviated when the child is on an intervention program. Similarly, concerns like impulsivity or the actual ADHD features could be presenting concerns. So they could be a comorbidity with the autism spectrum disorder that we can see with children, which must be ruled out again. Similarly, age inappropriate social interactions. So when I say age inappropriate social interactions, we need to understand that it is not always necessary that the child comes to us with a very poor social interaction, or say marginal interaction. It could be at times that the child's interaction is fair, but it is not age appropriate either. So that's where we need to understand and delineate that particular level where the child is falling short, and helping the child take him ahead from there. So we have common concerns, especially in school going children, and where teachers often give a feedback to parents saying that the child has a very poor peer interaction. The child is staying alone, not interacting with peers, and doing things more of solitary play, and not really following instructions in class, refusing to follow directives by the teachers. So again, we need to ensure that where is this coming from? Is this just the tip of the iceberg that the teachers are encountering in class and highlighting to parents? And is there something much below, much underneath that we have to be looking for? Do we need to see the root cause of this problem rather than just looking at the symptoms that may lie on the surface? So these are some of the very common behavioral challenges we most commonly encounter with children who are on the spectrum. So very importantly, this, as we see, is the aggression iceberg. And our job here is to actually decode the hidden message a child is giving us. So all these specific behaviors that we can see in the visual, the spitting at times, the irrelevant shouting, the throwing, the pushing, the hitting, it may sound very, very challenging, and it definitely will be very stressful for parents. So we really need to understand that where all this is stemming from. Definitely, it is not out of nowhere. Definitely, there is a reason behind it. However, the reason may be unknown to us, but there is a reason for sure. So we need to take a step back, look at the underlying deficits here. What is actually causing these specific behaviors? So one is the child could be unaware of social rules, because of which he's indulging in these behaviors, most likely. Unaware of others' feelings, unaware that this is not socially appropriate. Similarly, there could have been some trigger factors which may be annoying the child, and the child may trying to be expressing himself that he's not liking it, or he's averse to something, and he's just trying to express his needs and his emotions at that point of time. And again, inappropriate reaction to others. So these are all the underlying deficits that we actually have to watch for and look out and find out what is really behind them. So when we actually see a child with major behavioral challenges in development, or in any developmental concern, or specifically when we talk here about autism, first we need to understand the first thumb rule being every behavior has a reason. So as I mentioned, it is likely that we may have missed the reason, or the parents may have missed the reason for a cause, not understanding that where has this really come from, but definitely there is a reason for sure to cause this. So first, we always have to think of the ABC model. That is, A is the antecedent or the causes. What has actually triggered these series of events? We need to look back and record that. Second is the behavior. What is the challenging behavior that it could have caused or it has caused? And last, the consequence. So even though the behavior may make very little sense as to why this all of a sudden irrelevant behavior, but it is important to look at the consequences, as then we know how we manage that would determine if the behavior escalates or disappears. So most often here, we only see the behavior that the child has done this, but what is the antecedent, what is the consequence is often unattended. So as every behavior has a function or a purpose, we need to understand that we need to explain parents that they need to maintain a diary for recording these events. So paying attention to and recording the environment around and the series of events can lead to an understanding of triggers for occurrences. Secondly, we need, when a child, when we have ruled out that, yes, it has a reason, the second algorithm here would be to rule out physiological reasons. So something like the child is thirsty, the child is hungry, not able to express his needs, and the child is barely crying and getting very irritable. Yes, we need to definitely rule out that physiological reason there. Similarly, sleep issues. Has the child slept well? Or is there anything underlying, or enlarged adenoids, or the child is having a disturbed sleep? So rule out all those physiological reasons before we go next in the algorithm. That is, third, to rule out any kind of medical causes. Medical causes again here would be that the child could be unwell that particular day or unwell in the last few days, having a runny nose, having some kind of fever, abdominal pain, toothache, constipation. So very, very pivotal that all these medical causes are ruled out, because very many times, most often, very commonly, these medical issues are something that is commonly seen to be the cause of that behavioral challenge at that particular time. Once that is ruled out again, the fourth step here is again see for any kind of sudden change that may have been there in the child's overall daily routine. So any kind of change that has irked the child in any way. So what we really need to understand is that when a child has a fixed daily routine, it actually helps to, it helps the child, child's day be very predictable. So it forms a sense of predictability in that particular child. So the child understands कि उसके साथ क्या होने वाला है. Basically, he knows कि when I get up in the morning, my parents will take me to brush my teeth, washroom, breakfast, bath, all that step, go on, so on and so forth. But once this routine changes, for any reason, matter of fact, it again leads to more anxiety, and because of which the behavioral challenges are seen on the rise. So again, a very, very common cause that we need to, take in history, that why this cause of acute behavioral changes that could have been there, is it something that, is it this domain that we are really looking at and dealing with? Going ahead, there could be some difficulties in transitioning between unfamiliar situations, which is again provoking anxiety. So when I say unfamiliar situations, I mean that where the child is not particularly familiar or particularly comfortable in that particular social setting. So again, as we are aware that the child's adaptability here, is a concern. So here we need to make sure that where exactly on the development tract, as we had seen earlier, where the child is the child very averse to crowds at this point of time? Is he not very comfortable with strangers, or is he only comfortable with parents at this point of time? And we have subjected him to a group of, peers, or in school, a different setting. So there can be so many things, which could be out of the box for the child, something that is, far-fetched at this particular developmental level of the child, and because of which, it is just inducing more pressure to to perform here, and again provoking anxiety, and again leading to more behavioral challenges. Also, then we need to make sure that, is the child feeling threatened in any way? So is the child scared, angry, not very comfortable with the surroundings? Is there a stranger around and he's not able to express that he's feeling a little threatened? Similarly, communication barriers, very commonly, especially we see that in older children as well, wherein they are unable to express themselves, and because of which, the communication barriers actually cause, a lot of concerns for the child and their parents. Similarly, inappropriate caregiver response. So at times we do see that, yes, we do understand that parents are also going through their bit and are also very stressed out at the same time. But sometimes out of stress or parental fatigue, they may indulge into some kind of corporal punishment or some kind of, aggression or shouting at the child. And this kind of inappropriate caregiver response may trigger the behavioral challenges and may make it even more pronounced than what it was earlier to start with. And finally, concerns also like self-regulation issues can lead to aggression as a coping mechanism. So we most often see that when the child starts improving, doing better, the social connect is getting better, and now the child has come to a level wherein the child is now adapting to people, understanding social demands, understanding age-appropriate social behaviors, and in the process of actually getting these social behaviors right and learning them better, these self-regulation issues can come about. So it's basically that the child has full understanding that there is that he is doing wrong or doing a right, but because out of his impulsivity and self-regulation issues, the child gives into these behaviors and as a coping mechanism, often leading to aggression again. And again, yes, challenges in peer interactions or interactions at the levels that the child is yet not ready to be, and navigating different kind of social situations. So some places wherein it's a crowded train or a crowded religious place of worship or a crowded marketplace, for example, any place that makes him feel threatened and makes him feel challenged. So here, very importantly, as per the algorithm, we need to make sure where, what the hidden message is and what are we looking at. Now going ahead about how we can help the child cope with these concerns. So the first strategy here would be to understand the triggers. And yes, as much as possible, to avoid the triggers in the initial stages. So if we are aware that the child has a particular concern that he's averse to loud sounds, okay. If he's going out, if there is some kind of exposure in the background that he's getting because of that, and he's getting a little irritable, you can always calm him down, and that's fine. But purposefully, putting on a washing machine or putting on something that he might trigger him, or would not do better. Similarly, creating a structured environment for the child and creating a daily routine would help the child to cope with these behavioral challenges. Again, brings down the anxiety, helping the behaviors get even better. Thirdly, we need to provide very clear, simple, basic instructions wherein each task in the day can be broken down into manageable steps. So rather than making it, a big task at one go, help the child to do better in those steps. So for example, if the child has to visit a washroom, it can be broken down into steps. Putting on the light, taking out the pant, going to the washroom, again, flushing, cleaning himself, wearing the pant, coming out, closing the door, washing his hands with the soap, taking a napkin, wiping down his hands, and closing the light. So all these tasks can actually be broken down, in steps. This will help the child to understand better and help the child relate to those day-to-day tasks even better. Similarly, when a child's interaction gets better, it would be nice to offer choices, nice to offer preferences to the child and help the child choose what he or she likes. That would give him more opportunities to, again, decrease behavioral concerns. Again, avoid anxiety-provoking situations, especially when we are aware of what we had seen, all the trigger factors earlier, trying to avoid all those situations that may cause some sense of concern at that early point of time, before the child actually starts adapting to these concerns step by step as the child goes ahead, developmentally. And yes, definitely we need to make sure that all these triggers, which, were the trigger factors earlier for the child, now would automatically get alleviated. And going ahead, the child can actually overcome these and, do better, irrespective of them being present or not. And similarly, when the child has some kind of negative behaviors, some bad behaviors, the option here would be to tell parents to ignore the behaviors completely, because any kind of response would actually reinforce these negative behaviors in the child, and the child would do it even more repetitively when asked not to do it. Similarly, when we see a child has good understanding and the child is indulging in a so-called desired behavior, yes, always positively reinforce that behavior by immediately showing appreciation. One can just cuddle the child, give a high five, or just simply say very good. So show some kind of even non-verbal cues would do good here, to express to the child that you have actually noted these and appreciated the behaviors. Similarly, when any changes are anticipated, it would be a good option to prime the child in advance. So if there is any change in the schedule that one is tentatively planning, it would be a good idea to tell the child that this is going to be the we would be going here, for example, this would be the setting, you would be seeing these many people out here, this would be done out there. So basically helping the child adapt to it few days in advance, that the child can actually process that and help him perform better when he is in that particular social setting on that particular day. Similarly, creating more opportunities for appropriate social behaviors, very, very important. So again, it's more about, as we are aware that interaction is the dysfunction with the social interaction, the human connect. So now helping the child master the human connect and helping the child go ahead step by step into understanding appropriate social behaviors. So very often parents tend to misconstrue that social behaviors can only be perfected in the setting of a school or an academic setup. Most often not. So basically what we need to understand is that these social behaviors are most often and always picked up in the realms of one's home first. To begin with, it all starts with the family. Second, once that is perfected, then the child starts becoming more comfortable, and then the child understands these social behaviors and cues from his familiar people that he is aware of. Masi, Kaki, Bua, Chachi, all those people that who are not very different, but some little similar to the parents, because they are relatives, because they are cousins. So little variations here and there, and the child can actually adapt better to these people where the gap is not very much huge. Similarly, older children to start with would do better than peers at that point of time, because with older children, with older people, they would be the ones who would understand the child better, who would be willing to adapt to the child, who would compromise in their own way, wherein a peer at that point of time would do the same what that particular child would do. So would really be would not be fruitful to help him indulge with children at that point of time when he's yet not perfect with his parents and with his known family members. Similarly, role plays. So again, when the child is unable to understand how to appropriately respond to certain situations, to certain, settings, role plays here make a very different, make a difference to the child. So wherein helping the child understand that what, he's supposed to do and what can be expected of the opposite person, and then that helps the child cope up better. Similarly, ensure there's a good diet, enough plenty of water. As we are aware, a good night's sleep is very, very pivotal, which we must always, reinforce. Also, make sure that the screens are completely stopped, because again, a lot of, patterns, a lot of aggression and behaviors, and a lot of echolalia especially is picked up from the screens. So screens are a strict no-no for these concerns. Going ahead, we must monitor and see the progress of the child as to what has worked and what has not, because each child will be different. There will not be a single coping strategy that could work with all children uniformly. There would always be different strategies that we would need to, use as per the, developmental level, as per the concerns, as per the typicality of that particular child. And last is the self-care of parents. So most often, I have included this as a very, very important part of a strategy to cope as well, because most often, parental self-care is often neglected. And, parents often go into, that the thing of, sacrificing and doing everything for their child, but not understanding that, any, gaps in their self-care would ultimately also affect the child's, concerns, and affects the child's progress and optimal developmental functioning. So definitely, when we see a parent coming into us, it is very important to see that not only the child, but also the parent has to be coached, and the parent has to be, also, made more, strong with the coping mechanisms with the situation. So initially, as we are aware that, when the parent is given that, is told that there is a diagnosis of autism for their child, yes, most often we see that the denial phase comes in first. Going ahead, the resistance phase comes in, trying to struggle that nahi ho sakta hai, why me, why not? So many questions. And after which, there comes a phase of exhaustion. So again, exhaustion wherein the parent has accepted that, yes, these are the concerns. And now the actual, the healing of the child starts, wherein the parents are prepared that, and they see that where exactly the beginning has to start taking place from. So yes, of course, we see that so many, concerns or so many other challenges that can actually, intensify these stress levels in parents, be it, say, family demographics or economic resources, the maternal coping, stigmas from society, also altered sleep patterns with parents themselves. So parents are, have not had a good night's sleep since years, and they are struggling. How can we, expect them to, be strong, be perfect, and, do and what needs to be done for that particular child? And all sorts of new routines that have come up because of this child, and, trying to adapt to different things. So definitely, we would see stress reactions come up in them, sleep disturbances, headache, bodily issues like neck ache, back ache, hypertension, and stress, fatigue, mood changes, anxiety. So all these concerns actually, build up with time. So what we really need to, express to them that there is no such thing like a perfect parent, because every parent tries to do his best, but feels that, does not realize that there is a certain limit that, one can really do. So parenthood definitely is challenging, and sometimes we forget how to just be a happy parent in the midst of it all. So again, with that, there are some past family conditionings that have, irked the parents, and they have been, forced to deal with the child in a particular way, especially when the child is not on an intervention program, when the parents are not guided the right way, and where most often it is, it is misconstrued that intervention to khali bacche ka hona chahiye. But more than the child, it is the parents who require the coaching, the parents who require the, an intervention from that perspective to help the child get better. So again, they need to realize that they must be willing to question what they prioritize as a parent and why. Similarly, shouting, use of harsh words definitely should be avoided, as it frightens the child, it intimidates the child, it destroys the trust and a child's feeling of safety. So they need to pay attention to circumstances when they shout and then commit to change those scenarios. So again, as a parent, they need to be aware that they must embrace their imperfections, and the best parents are willing to always learn, change, and improve. Compulsive worrying does not make the child safer and the parent happier. Work towards the child's, step-by-step progress. Rather than seeing the overall picture, document the step-by-step, small milestones that the child is achieving day to day, which is actually helping the child, achieve bigger and help the child come to that optimal developmental level where the child is supposed to be at that particular time, the age-appropriate level. And very often we need to remember that no one size fits all. Each child is different, each family is different, and they need to also, parents need to realize that they should not compare and contrast their concerns, the child's challenges with other children, because everyone will be at a different developmental level. As a parent, one definitely does give generously, but just because you are a parent, one should not give up your core self. So we must make them more aware that they should not be ignoring their basic needs, and definitely their self-care would help them go a long way in terms of childcare. And definitely no negative feedbacks, but obviously parents are stressed out and they may give some kind of negative feedbacks that may not be well aligned to the concerns of the child, to the improvement of the child, and that must definitely be avoided. So as we see that in any kind of situation, most often anxiety is the causative factor which is underlying these behavioral challenges most often. So our motive should be to decrease, alleviate this anxiety, help the child's interaction get better developmentally, help the child's social behavior get better accordingly. This will also increase his receptivity to learning methods and thus also help his expressive communication going ahead to get better. As we are aware that behavioral intervention, and with a proper intervention, a customized, individualized plan for the child is very, very important in dealing with all these concerns and along with these behavioral challenges for the child. So psychopharmacologic interventions are also done. They also target associated disorders like depression, anxiety, aggression, hyperactivity, sleep disorders. So they basically help improve the child's functioning and the ability to participate in behavioral interventions. And they must always be used in conjunction with appropriate interventions and not only as a standalone therapy. So this is a consensus statement of the IAP on Evaluation and Management of ASD 2017, wherein the drugs available for pharmacological management of ASD are mentioned with their doses. So one can go through this as well. Similarly, we have specific pharmacological treatments for all the other concerns. After we've ruled out, what we have, what we actually come to the interventions and when we are dealing with pharmacological treatments. So most commonly we use drugs like methylphenidate, risperidone, fluoxetine, and occasionally melatonin to help these children do better in terms of behaviors as a supportive strategy to overcome these behaviors in a faster way. So with that, I would like to end my talk. And thank you once again for giving me this opportunity to be a speaker here today. And we have, as we are aware, that New Horizons has opened up now even at Vasai with our other 5 centers running as well. And in fact, we have weekly OPDs, as Dr. Gokaran ma'am has just mentioned. So if any challenges, any concerns, please feel free to reach out to us as well. It was wonderful being here today. Thank you.
Thank you, Hila. So much knowledge. So much knowledge to learn from you. And still we want to learn more about autism now. And as we say that 2nd April is an Autism Awareness Day, where we are like having awareness, acceptance, and appreciation as 3 A's as a treatment for autistic children. Thank you so much.
Thank you so much, ma'am. It was my pleasure. being
Thank
here.
you, Dr. Hela, for a very brief and very fantastic presentation. I think today we had a very good talk from both Dr. Leena and Dr. Hela. I think the development pediatricians are a special breed of pediatricians which are super intelligent, super patient, and very caring. So it was a very nice talk, Dr. Hela. I would like to ask you a few questions.
Sure, sir.
Dr.
A year or
Shailesh
two ago,
also
we
wants
had a talk on autism. Year or two, same IIP over there. There, I don't remember the speaker. They said no omega 3s, no Ayurvedic medicines, no. So, what is your take on these things there now?
Yes. So, in fact, these forms of therapies, which are often what we call as nutraceuticals, are very commonly prescribed. However, it is not really scientific and evidence-based. So, at our place, we honestly do not have, we hardly use these kind of medications. So, it just helps that, if the parents feel that the child is bettering in any way and, they would like to continue, that can be done, because definitely it does not cause any side effects. So homeopathy medicine, some Ayurvedic or omega-3 can be continued, but it actually, there is no relevance to the improvement or the functional improvements that we see in a child. So definitely would not be recommended from our end.
Okay.
another comment from Dr. Shailesh. Dr. Shailesh?
Question actually. Madam,
Yeah,
you
question.
presented your fishbone, right? The development wise.
Yes.
In that, you said that first, second, third, and fourth stages are there. But most of the time, the patient does not come in a stage wise. They are different. The adaptability or the angriness or the social behavior or the language development is totally different at particular when the patient comes at 3 or 4 years. They have achieved different milestones at a particular age. So whether the same fishbone applies for all the kids or the fishbone changes according to the patient which presents to you at that particular uh, uh, stage or on that particular day. That is my first question. Second thing, it was an excellent presentation, but the practical scenario is different at particular different places. Like from most of our patients are from the middle class or from the lower middle class. Both the parents are earning. Both the parents leave at 8 o'clock in the morning or 6 o'clock in the morning. They travel 2 hours and then they come back traveling 2 hours and they work for 8 hours. So almost for 12 hours they are out of station, out of the house. They hardly intermingle with the kid and they are themselves are frustrated when they come down. There is either a nanny, means nanny is your aji or your dadi, not nanny, they can't afford nanny, or some caretaker, or they are in either some babysitting. So whatever the things you mentioned to see for the uh, basic the problems and the problem, what is the cause for the problem, it's very difficult to monitor for them. So any takes on that?
Yes, sir. Thank you for your question, sir. Answering the first question about the fishbone and explaining how we really demarcate that child on that particular fishbone. So yes, this social behavior, the NHSBC sequence that we have seen there, is a theory of social interaction that we have hypothesized and we have come up with at New Horizons itself. And this is used for all children coming into us with autism spectrum disorder. This helps to demarcate or delineate where the child is currently at what particular level in each of these specific domains. Secondly, once this delineation is done as per the standard methodology, a customized, individualized plan is accordingly made for that particular child, with respect to his different parameters, like the developmental level, the functionality, the caregiving responses, the parental the parental part, wherein are they working, are they at home, similarly where the child is on each of these domains. And then according to standardized algorithms that we have, these individualizations are done and the plan is accordingly delivered to the child with specialists. So basically the goals are actually written down by the developmental pediatrician based on these concerns and based on the level where the child is today. And accordingly, the plan is individualized and customized then. Second, with respect to the second question, sir, about most often, as you rightly mentioned, sir, that we have so many parents coming into us who are most often working parents, and often, yes, some concerns, wherein they are not able to devote that much time. They are themselves stressed, fatigued. So what we usually, is recommended here is that we really don't want that the child should have the biological mother or the biological father actually interacting or doing what is advised or what is being coached. It can be any human. So any human that there is an adult who is willing to interact and engage with the child. So it can be just if the parents are, yes, affording, and they can manage to keep a caretaker at least for that particular time wherein they are away, that could suffice. Second option could here again be that the parents could take turns and at workplaces, so the timings could be accordingly coordinated. Third is if the parent can take a sabbatical from work, if that's okay, and for a 3 to 4 months. And if we feel that the child's interaction really requires a lot of work and we need to get better there, we do advise the same as well. And otherwise, the child can have any known relative, a masi, or a family friend who is willing to spend some hours in the day with the child. So even they can be called home, they can be called and included in the intervention sessions, the coaching sessions, and coached as to what we really require that needs to be done. So these are the multiple options that we can suggest going ahead, depending on the concerns and what background and the demographics demand. Yes, sir.
Thank you so much, Dr. Shailesh and Dr. Hila. We can learn many things from you, and the meeting will go on and on. So many questions are now in our mind, but we are short of time, and I would like to Dr. Wasim to introduce Dr. Amit Watkar, sir.
Yeah, thank you, madam. Dr. Amit Watkar will speak on epilepsy drugs, recent advances. Dr. Amit, are you there?
Yes, he's there.
Dr. Amit Patkar is a very senior pediatric neurologist. He visits Vasai and Virar every Thursday, and he has been very, very helpful to many of our patients, and we look forward to his speech.
Okay. Yes, sir. So you're ready, Dr. Amit, sir?
You're on mute. Amit, you're on mute. Dr. Amit, you're on mute. Dr. Amit.
Yes. Amit, unmute कर.
आता
येते ना?
हो.
मराठीत बोलल्यावर कळलं काय? Well,
yes,
so
sir,
what
please
I would try and give you an introduction to few of the new drugs which have been recently introduced. Now, epilepsy, since a long time, there were not many drugs till almost 2 to 3 years back. It was same drugs which we were using, but then still there was always a thing that whether we should use those traditional 4 drugs or then move on to other drugs. So I will just revise some of the few basic concepts. Seizure. So what seizure? Basically, seizure is an episode of altered behavioral awareness. It can be with body movement. If it is with body movement, it is called as convulsion. When it is with body movement or without body movement or any other feeling, then it is called as seizure, which is caused due to the excitation of nerve cells. Epilepsy is a tendency to have recurrent seizure. A single seizure can be experienced by anyone. There can be many factors that can cause a single seizure. But when there's a tendency inherited to have repeated seizures, it is called as epilepsy, which is itself a disease. And acute symptomatic means that what I say, like a single seizure. So if there is some damage to the brain, or there is some hypoglycemia, or there is some hypotension, and because of which the child is throwing a seizure, that could be acute symptomatic seizure. So primarily what we are worried about is the epilepsy. Why epilepsy? Because in epilepsy, seizure can take place at any time, and when it can take place at any time, when there is an uncertainty associated with occurrence of seizure, the life of the child comes to stake. So we don't know whether he's going out, he may have a seizure, whether he's sitting at home, he may have seizure, he may have seizure anytime. To remove that uncertainty, we need to treat it. So
initially what it was that whenever there are two unprovoked seizures more than 24 hours apart. Why? Because when there are two unprovoked seizures more than 24 hours apart, the chance of getting a third seizure was more than 60%. So 60% is a high risk to be taken. So they thought that, well, we should classify this as epilepsy. But then as the things progress, they realized that only when there is one seizure and having a second seizure, the chance is more than 60%. In this case also, we should classify it as epilepsy. So what they say, if there is an abnormal examination finding, like if there is a neurodeficit, then we say that the chance of having a second seizure is more than 60%. If there is abnormal neuroimaging, that means you image the child and you find there is a stroke, or you image the child and you find there is a NCC, or you image the child, you find there is a tuberculoma, then the chance of having second seizure is also 60%, or an abnormal EEG. So you do a EEG and you find there are focal epileptic discharges from one side of the brain or from bilateral, and you just had first seizure. In this case also you treat it as an epilepsy and then you manage it accordingly. Or when there is a specific epilepsy syndrome like infantile spasms, well, they have many. Like if there is a Beck's, so only Rolandic epilepsy where the child may get seizures in the night. So if there is a diagnosis of epilepsy syndrome, in this case also you directly label it as epilepsy and then you move on with the appropriate line of management. So with the new classification, they removed all those previous things. They just kept generalized onset, focal onset, and unknown onset. Like in spasms, we don't know from where it is originating. Then they classified epilepsy types. So these are seizure types. That means the disease. What way we are able to see. And in epilepsy types, generalized. That means when it arises from both the parts of the brain, focal epilepsy only from focal, combined generalized and focal and unknown. So they may have focal or generalized. And etiology, so initially what was idiopathic, they removed that idiopathic and placed all the genetics and unknown in idiopathic. Then they have another thing, structural, infectious, metabolic, immunological. As one will move on with the investigations, one may able to find more specific etiologies which are causing the seizures. So as per our Indian studies, it's almost 4 children per 1,000 who actively suffer epilepsy in India. So globally, there are many. So we can say almost as good as 3 to 4% globally also are affected by epilepsy, both adult as well as children. But children bear the maximum burden because the children, it's a developing brain. All the wire settling is not yet done. So there are more chances of getting a seizure in children, and the second age group is the old age, when it is a degenerating brain. Even in that cases, there are more amounts of getting seizures. Causes could be, as I mentioned previously, genetic, congenital, severe head trauma, ischemic injury, and etc. So in this EEG, what I need to show you is how the seizure evolves. Now you need to see specifically at the first slide, there is where it is normal, you can see just interictal discharges at right-sided temporal region. As you move to the second slide, you can see they are getting more synchronous at right temporal, and then you see that it is getting generalized. So when we see the child in the generalized, that means when the seizure has moved to both the sides of the brain, the consciousness being retained is usually not possible. So sometimes you may see a child who is shaking both his hands or both his legs, but the child is conscious. So usually that is not a seizure. So whenever a seizure involves both the sides of the body, the consciousness goes off. So only both hands is not a seizure. Only both legs is not a seizure. It has to travel from one part of the body to another part of the body. And that is the way we should say that every seizure should have a pattern. It cannot be 2 hands consciousness retained, 2 legs consciousness retained. Okay, so lots of pseudo seizures are there, and this forms a very important differentiating point. So treatment. So whenever you have to treat a seizure, you have to find out why it is there. So it could be as a febrile seizure or a head trauma or drugs, especially in older kids. Recurrent seizures that cannot be attributed to any other causes are seen in patients with epilepsy. So therapy, so main choice of therapy, you should have a choice of drug which can be decided based on what type of seizure it is. Like for generalized, it is different, focal it is different, spasms it is different. But as we move ahead, drug side effects are more worrisome, and they are an important basis on which you can decide which drug is to be used. So more than 80% of patients with epilepsy can have seizures controlled with medication. Those remaining 20, you have to fight over it. Means you can do epilepsy surgery, you can do VNS, and there are hundreds of things that come out. But many of them, even though what we say that after 2 appropriate drugs in appropriate dosage, the third drug giving a chance of improvement is less than 10%. But well, for a patient, if it works, it is 100% for the patient. And if the patient is not a surgical candidate, then definitely something we should try and make him work, because whatever we are going to try on him is going to be 100% for him. Okay, so whenever you get a epilepsy diagnosis, first thing comes to mind is how should I treat it? What drugs? First, always remember that you have to have a proper diagnosis. EEG usually points you towards the diagnosis, but the clinical scenario, the way the child had a seizure, is of crucial importance, because that is what identifies most of the thing. In EEG, you can find a focal or you can find a generalized, but on a clinical, if the child has an aura, you know that this is focal. So when there is focal, but the EEG may sometimes mislead, but whenever the EEG shows focal, it is almost always focal. So as I said, after 1990, there were lots of drugs that came into the market. So it was because what they subsequently realized that, well, with the previous drugs which we are using, even though the seizures has come under control, the side effects, then the knowledge started growing and they started thinking about what happens to the fetus. Then when the people who are on multiple drugs, as they started improving, they started thinking about drug interactions. So interactions, pregnancy, and side effects. So these are the 3 factors that led to development of newer drugs. Now these newer drugs, most of them are lab synthesized, means a target is decided and then the drug is manufactured what way it can go and precisely hit that target. For example, breviracetam. So breviracetam came out like a flood. So after levetiracetam was working well, breviracetam was almost everywhere. Brevipil, brevizam, brevicetam, and brevap. So there were lots of brews everywhere. Why? Because this breviracetam was synthesized in a lab with the sole purpose of reducing the side effect of levetiracetam, but increasing the efficacy. Unfortunately, in the market, the efficacy did not prove that much. Similarly, other drugs like cannabidol, which is just now a new baby in the market, this is because of the old gained experience that cannabis affects the CNS and it has been granted or permission to be used in specific type of resistant epilepsies. So I will try to highlight few of these drugs which are available with us and easily available in our Indian scenario so that we can use them appropriately. So still, whatever it is, in tonic-clonic grand mal seizures, the first drug of choice remains to be valparin, topiramate, and lamotrigine. Now, as we consider towards the younger age group, pediatric age group, but when we move on to adolescent, valparin is not that favored because of its side effects. So there, the favored drug has turned out to be levetiracetam. Alternatives could be carbamazepine, but one should be aware of rash, and phenobarbital and phenytoin are almost out for the generalized tonic-clonic seizures because of their bioavailability and their behavior side effects. In partial, oxcarbamazepine is far better than what we said, and so in partial, oxcarbamazepine remains to be a drug of choice unless in few cases where ox can cause apparent worsening. In those cases, valparin comes to rescue. So in absence, ethosuximide has been recently made available in the Indian market. Initially, it was valparin and lamotrigine who used to be there, but with the advent of ethosuximide, ethosuximide is an excellent drug for pure absence seizure. Sometimes absence seizure can be a part of juvenile myoclonic epilepsy, in which case ethosuximide doesn't work as good as valparin. In myoclonic atonic, still again valparin in status epilepticus, after giving lorazepam, diazepam, phenytoin, valparin, levetiracetam, all the drugs almost line at the same level. So this is the new advance with case of status epilepticus. For febrile seizures, as always, midazolam and diazepam are there. So first generation drugs, they are very good for that matter. But if you consider their side effects, you have to think that can we offer a better alternative. So incomplete efficacy, complex kinetics like for phenytoin, phenobarb, you have to monitor the levels sometimes, and a very narrow therapeutic range, adverse CNS effects and drug interactions. In second generation, they are more safer than what the first, because they are, most of them are derivatives of the first generation, but they are relatively safer because when they were made, the safety was kept into mind. So even though they are not that potent in few cases, but because of the safety, they stand the drug of choice. Less drug interaction, no need to monitor the levels. Few of them are in XR preparations, which can be used single or twice daily. Better tolerability, but more expense. So in a patient who cannot afford newer drugs, you have to stick to older drugs. But despite of that, because of the government policy, the drug cost has been significantly reduced, and nowadays, instead of going to phenobarbital or phenytoin, valparin, levetiracetam, topamac are easily available even at the government institutes. So they have established, when we say that carbamazepine or valparin has failed, which are the two major blocks in the first generation, you have to move on to the second generation. Especially in women where there are OC pills or where there is pregnancy, you cannot risk giving carbamazepine or valparin, and you have to move on to more specific drugs. So as an add-on therapy, in case of refractory epilepsy or in case of LGS, you have to have higher, means newer drugs, because of their good pharmacokinetics, and they can be easily combined with other drugs and an excellent result. So first drug which I would like to discuss is divalproex. Now divalproex is the brother of valparin. So only thing that when you give valparin chrono, it's twice a day, but when you think of valparin syrup, it has to be ideally given 3 times a day, even though we give it 2 times a day. So when in larger doses, it has to be given 3 times a day, and valparin is available in 200 milligram per 5 ml quantity, while divalproex is also available in 500 milligram per 5 ml, which makes easy to dispense even a large amount of drug to a kid. It is equivalently efficacious as compared to valparin, so it can be used in absence, myoclonic, tonic-clonic, especially if you have migraine, you have maniac episodes or behavior things. In case of autism, if you have mood disturbances. Side effects are same like valparin: weight gain, alopecia, thrombocytopenia, and occasional hepatotoxicity, which can be fatal. So not given below 2 years of age. Advantages can be given as 1 daily dosing. So broad spectrum of action and mood stabilizing effects. So as compared to valproic, better gastrointestinal tolerability, but similar efficacy and safety profile. So we can give divalproex in place of valparin in children who use syrup and require larger doses. Oxcarbazepine. Now oxcarb is a brother of carbamazepine. So it blocks sensitive sodium channels, protein binding is less. It has to be started at a very low dose. So what we normally says 20 milligram is the standard dose, but we have to start it as low as 5 to 8 milligram per kg, and then increase it every third day till you reach a target dose of 20. It can be given maximum up to 40 milligram per kg. It is metabolized in liver, so kidneys are spared. Plasma half-life is 8 to 10 hours, so you can give in BD combination. no autoinduction, fewer drug interactions with carbamazepine, lamotrigine, whereas carbamazepine has lot of interaction with phenytoin, phenobarb, valparin. But oxcarb has very few interactions, so it can be given simultaneously. It can be also given along with warfarin, cimetidine, erythromycin, and verapamil. Third drug is breviracetam. Breviracetam is the brother of levetiracetam. As I mentioned initially, for partial, focal, generalized, highly resistant, it can be used almost for anything. It has a high affinity for synaptic vesicle protein 2A. So this was the target which was decided, and the drug was modified for the target. So dosage is almost 10 times smaller than what levetiracetam we give. We give levetiracetam 10 to 20 milligram per kg. Breviracetam is given to 0.75 to 1.5 milligram per kg. And a maintenance dose of almost 2 milligram per kg twice daily. Ethosuximide. So even though I have mentioned here, why? Because this has been made recently available in Indian market, and previously it was not available in Indian market. So ethosuximide has a half-life, a good long half-life. So even if a single dose is missed, it doesn't matter. First line of drug for absence seizures, but it is not to be used in partial and tonic-clonic seizures. So valparin, in some cases where you are not sure or where the EEG is not as for absence seizure, that means EEG can show spike and wave, but if it is a fast spike and wave or a very slow spike and wave, in those cases you have to use valparin and not ethosuximide. So it can have adverse effects like psychotic behavior, blood disorders can be there, persistent headache. And in older children, there can be tremors and photophobia. Lamotrigine is an excellent drug that has come to a great help as a assistant of valparin. So valparin was used, and I'm sure it will be used because it almost acts in all types of epilepsies. So lamotrigine has come as an assistant of valparin, which acts through a different way. But the only thing fear about lamotrigine was that it can be used in almost all the seizure cases, but it has a rash. So lamotrigine has a rash which can be very severe and can lead to Stevens-Johnson's. So this was a fear with lamotrigine, but we have to realize that this rash is dose dependent. One more thing, lamotrigine has less cognitive dysfunction, has a positive psychotropic effect. So valparin is also used for where you have mood disturbances. Lamotrigine is used where you have mood disturbances, especially used in women and older children. Lamotrigine doesn't affect weight. So in cases where valparin cannot be used because of its weight gain, lamotrigine plays the upper hand. So whenever you start a dose, it should be as low as 0.15 milligram per kg per day for 1 week. Then you can gradually increase it, especially with valparin. Now 0.15, if you consider a child of a 10 kg, so 0.15 will be as low as 1.5 milligram. But the dose, the tablet comes in 25 milligram formulation. Initially, there was a tablet which was in 5 milligram formulation, which was now out of market. So now the tablet is in 25 milligram formulation. So whenever you need to start valparin, you need to break the tablet to 1/4 or half, dissolve that in 5 ml of water, and further reduce the dose at least for initial 2 to 3 weeks. Then you can reach up till 5 milligram per kg per day. That means for a 10 milligram child, 10 kg child, 50 milligram of tablet. That means 1 BD can be used as a full dose. That would be the maximum dose with valparin. But to start it, you have to start almost 1/10 of a dose. By doing this, you reduce the chances of getting a rash. And lamotrigine has helped wonderfully in many of the severe epilepsy cases who have been refractory for almost decades. So topiramate. So topiramate acts through carbonic anhydrase and sodium channel glutamate. The initial dose is same, like 1 milligram per kg. You can go up till maximum of 10 milligram per kg. So it has to be increased very slowly, drug interactions are less, it is effective in all types of epilepsy, in focal, generalized, refractory, everything. It is also used in refractory neonatal epilepsies. In neonatal epilepsy, levetiracetam has been used in a big way. So levetiracetam and Gardinal, and if the child further goes to be refractory, valparin is usually not administered in neonates because of its hepatic thing. But topiramate plays a major role in neonatal epilepsies. Topiramate is also used in cases of epilepsy with migraine, and because it has a major side effect of weight loss, in those cases where valparin causes weight gain, topiramate can be used instead of it, as it helps in weight loss. So zonisamide is in similar way acting to topiramate. It can be used in all those conditions in which topiramate is used. It is also started at a low dose of 2 to 4 milligram per kg per day, gradually increased to 6 to 8 milligram per kg per day. Only thing, zonisamide is available in capsules, so it's not that frequently used. So common side effect is sleepiness and dizziness. So these are the very two common side effects with zonisamide. Lacosamide. Now, when they started studying valparin more in adults, they found that valparin cannot be administered freely to adolescents and adults because of the effect it has on teratogenicity, cosmetic side effects, the effect it has on menstrual cycles. They have also come out with the thing that valparin can also affect a dose-related response on the fertility in men. So due to this thing, subsequently they came out with a better drug, safety-wise, lacosamide. So lacosamide has been recently gaining its approvals in almost all the sorts of epilepsies, even as an IV and even as a first-line drug of choice for generalized epilepsy in adults. So starting dose is 2 milligram per kg per day, maximum one can go up till 12 milligram per kg per day. So it has a novel mechanism, that means it was developed major cardiac monitor for cardiac conduction abnormalities like PR prolongation. So vigabatrin. So vigabatrin is a unique drug because it helps in the cases of infantile spasms. Now, infantile spasms is a pediatric epileptic emergency. Why? Because more the days the child has infantile spasms, the IQ points of the child decreases. Even if you are successful in controlling the infantile spasms, the IQ point starts decreasing. So we have to control it as quickly as possible. So vigabatrin, initially vigabatrin was not available in India. It used to be black marketed. But now there are almost three companies who have come up with vigabatrin sachet formulation. So a sachet and a diluent. So you have to mix the sachet in the diluent and give it. So it can be used for infantile spasms, especially in case of tuberous sclerosis and refractory complex partial seizures. So we start at a dose of 50 to 150 milligram per kg per day. First dose, you can go up till maximum of 150 milligram per kg, and you can increase it every week. But in infantile spasms, you can increase it every day because there it's an emergency thing. Adverse side effects is visual field damage. So in this case, in children, you usually don't give it above 8 months. And if you need to give, you have to monitor the visual field damage. So periodic ophthalmological examination and assessment is necessary. Gabapentin. Gabapentin is mostly used in adults, but in children, it can be used as an add-on therapy. 40 milligram per kg per day is the ideal dose, which has to be given in 3 divided doses. Now it is to be used, it is being increasingly used in cases with dystonia. So in neonates where there is kernicterus or because of some brain damage, HIE, there is dystonia. In this case, gabapentin can play a role in controlling epilepsy as well as dystonia. So it has a neuropsychiatric side effects like emotional liabilities, aggressive behavior, or hyperactivity, which should be monitored. Pregabalin. Pregabalin is similar to gabalin, acts on the GABA receptors, adjective for partial onset seizures. So it is used as an adjunctive therapy for refractory partial seizures. So more than 50% of seizure reduction, not 100% of seizure reduction. So common side effects are somnolence, dizziness, ataxia. Perampanel. Perampanel is a newly brought drug which used in almost all the types of seizures in children. It can be given once a day. It is usually given in severe refractory seizures. Why? Because the side effect, drowsiness, is excessive. So it causes excessive drowsiness and dizziness. So it has to be started at a very low dose and then gradually increased. Cannabidol. This is the last drug, most recent drug which is there. And unfortunately, in India, cannabidol doesn't fall into that X category of drug, which requires specific pharmacies to maintain the record. License has been given to almost all the companies. So everyone are marketing it. Cost is 15,000 to 8,000 per vial. It is available only in oil formation because that is what acts best. So it has been sanctioned for specific diseases like LGS, Dravet, tuberous sclerosis, and off-label has been used for refractory seizures which are not responding to any other drug. So starting dose is 2.5 milligram per kg twice daily, can be increased to a maximum dose of 25 milligram per kg, almost 10 times. So it has a novel mechanism of action like endocannabinoid system. Now initially this drug was still used even initially as medical cannabis, but this is the more refined form in which the addictive part, THC molecule, is removed and only the cannabidiol part is kept, which helps in controlling the epilepsy. So I have started myself on 3 to 4 patients and I did not find any of the side effects, at least till now, in them. And 3 of them have responded who were refractory infantile spasms. 3 of them have responded to the drug. But then, as I say, just getting response in small period of time is not enough. There has to be a long-term follow-up for any of these new drugs, because we never know what will be the thing that will be coming later on as they take for more amount of time. Monitoring the liver function test is an essential thing. Now, because it is in formulation of oil, they can get diarrhea, but it is basically a rapid clearance of the intestinal content because of the oil formulation and not the diarrhea. So the drugs which require titration, lamotrigine, oxcarb, topiramate, zonisamide. So all these 3 to 4 drugs require titration. Levetiracetam does not require titration. So in refractory IG, topiramate can be used, gabapentin has been used, LGS, lamotrigine, topiramate, gabapentin, tegabin, oxcarb, levetiracetam. So in LGS, our main aim is to improve the quality of life in the kid, because the child who is getting daily seizures will not have a good quality of life, especially those daily seizures where there are head drops. So in this case, all the drugs have been given a license to be used so that at least the child may improve. As we move ahead, there is a precision medicine that is coming in a large way, especially now with genetics coming at a very cheaper cost, available almost at doorstep, and where you are able to find more and more target molecules like SCN, TSC, like KCNT, where in KCN potassium channel, the sodium channel drugs like carbamazepine and phenytoin act well. So which were going off the block are re-emerging as a use in potassium channel encephalopathies. A new drug, fenfluramine, which was initially used as an appetite suppressant, is been released for Dravet syndrome, despite of its cardiovascular effects, because in Dravet syndrome, where the brain is going to get affected so much, the drug has been given a new approval. Everolimus, which is an mTOR inhibitor, has been given approval in tuberous sclerosis, because in tuberous sclerosis, whatever possible to improve the quality of life can be used. So newer, not I won't say newer, but vagal nerve stimulation is being done in a large way, which helps in improving the quality of life, but not seizure freedom. So VNS helps in decreasing the seizures more than 50% in more than 70% of cases. So transcranial magnetic stimulation is not yet been tried in India, but abroad it is being used commonly. Deep brain stimulation, especially for epilepsy, is not yet been tried in India. It is been tried for dystonia in India, but for epilepsy, it is not yet been tried in India, but is used abroad. So these are the new things which we hope will be coming in the near future, especially for those refractory and non-surgical cases. Yeah, thank you. If any questions, I would like to take them.
That was an extensive,
Yeah.
valuable talk. We are really
I agree, it was quite
overwhelmed.
theoretical
Yeah.
talk, but then when it comes to drugs and when it comes to pharmacology, so there
I
is
know, I
hardly
know.
any
Then
escape.
it's really, really important that now we have understood that there are so many new therapies available for the resistant patient or who has got a resistant seizure disorders. I would like to, like, if you can share your number, we can like refer the patient to you. And Dr. Amit Watkar is coming to Ankur Hospital.
Yeah, I come Ankur Hospital regularly on Thursday. On the same day, I come to Vasai Hospital, Vikas Hospital at Vasai also.
Thank you so much, sir. Please share your number. And Dr. Amit Watkar is also a head of the department at Rajawadi Hospital and also an honorary neuro pediatrician at MGM Hospital.
MGM Hospital.
So we are really happy and honored to have you, sir. Thank you so much.
Thank you. Thank you.
Thank you, Amit sir, for a very fantastic brief update. I think Anjali ma'am, you're ready with your presentation, ma'am.
Yeah.
Interesting cases.
Can we have Dr. Tanu first? Because Dr. Tanu has to leave then.
Yes, ma'am. Yes.
Dr. Soumya, will you present? Dr. Tanu is there?
Yes, ma'am. I'll present now.
Yeah, and
Okay,
Dr.
ma'am.
Tanu is around. She was to give expert comments.
She was
Is
there,
Dr.
but I think we are all late, so she must have been left. She was there for some time. Yeah.
Can anybody see Dr. Tanu? If she's not there, we can go ahead with Anjali. No problem.
I think ma'am has left. Anjali
Okay.
ma'am.
Yeah. I'll present.
Yes,
Yeah.
ma'am. Yes. Yes.
Okay. Mine is a very brief case. Can you see my presentation?
Yes.
Yeah.
Yeah. There was a 3-year-old boy who came to us last month, and he came with history that the father said that he has not passed urine, and he goes and he strains and he wants to pass urine, but he cannot. So obviously he had some kind of obstruction. There was no pain, there was no fever, and he never had a previous history like this. So we got an ultrasound done, and this was what the ultrasound said. And this was so many calculi seen that I thought I'll make a diagram. And this is what the diagram showed. This is the left kidney, the right kidney, and the left kidney shows that there are two of the calculuses which had calculi. The middle calculus had a large one of 5.6 millimeters, and there were multiple in the lower calyx. And on the right side, there were in all the calculuses, there were calculi. There was cystitis and there were floating bodies, and there was one in the right ureter, but there was no calculus that she could see in the bladder neck. So she didn't know where the obstruction was, but obviously the bladder was up till the umbilicus, she said, the radiologist. So we referred to Dr. Shalil. Now, Dr. Shalil was also going to speak over here. And the patient went to Dr. Shalil and he had to be catheterized. He passed a lot of urine, was very relieved and was very active also. He was active even before. And the parents refused to do anything more in spite of seeing so many calculi everywhere. And they had the catheter in C2, and they said, no, we don't want to get operated here. And for 6 days, he kept moving up with the catheter from hospital to hospital, had gone even to DM Petit Hospital and many other hospitals, and ultimately landed up again with Dr. Harshad Patil. And they did a cystoscopic urethrostomy and no, what is that? They crushed the stone and
Ma'am, I'm here.
yeah.
Hello, good evening, ma'am. Shalil here.
Oh, Shalil, you're here. Oh,
Sorry,
great.
I had to meet in between.
Yeah. So we have to be very brief. We have to run through this because
Yes.
there is one more other presentation. Yeah. Go ahead, Shalil. Should I stop mine?
Yeah.
Yeah. So it's preferable you just share your experience and not share any slides or go through the slides very fast.
It was like a very fast. The slides don't have too much anyways.
Yeah, sure. So this is the first time I have seen a 3-year-old child with so many renal calculi. And so I thought that this is a very unusual presentation and that I will have Dr. Shalil speak about the surgical management and have Dr. Vaishali More speak about the medical management of this child here henceforth. Because obviously this child has some precipitating factors which are making these stones. And this child will have to be monitored for a lifetime. Because already the right-sided kidney. Shalil, just speak if you don't mind.
Is my screen visible?
No.
Okay. Let me just try it one last time. Otherwise.
Yeah, sure. And so I thought that, yeah, we can see your screen now.
Okay. Where is it? So yeah, good evening, everyone. So as Madam said, firstly, patient came into retention. He had a history of constipation and dysuria both. So initially when he came to us, we first catheterized the patient and also gave an enema. After that, he passed some stool and then on catheterization, his obstruction was relieved. He refused admissions for whatever reasons, but then came back 6 days later with again retention. In the meanwhile, he got his catheter changed in one of the government hospitals. So we did an X-ray. X-ray showed that there was a bit of dilated bowel loops, but if you look closely, you can actually see the stone. So that stone which Madam was saying was in the lower ureter on the right side has already actually come in the bladder. So that made our job a bit easier. So he underwent a cystoscopy with a cystolithotripsy. We fragmented the stone and were able to remove it urethrally. And post-operatively, we kept the catheter for about 24 hours and then said third day he's gone home. He's not come back since surgery, since the surgery. Like I asked Madam, so he's not come back to Madam or me. So we're just wondering because this patient needs follow-up, especially with Dr. Vaishali Madam. So just briefly, stones are of 5 types, mainly calcium oxalate, which is most common, phosphate stones, uric acid stones, and cystine stones cannot be seen on the X-ray. And then struvite stones and some of the new ones are drug-induced stones like indinavir, which can cause stones. For diagnosis, we didn't need an X-ray, ultrasound. On X-ray, most of the radiopaque stones are seen. Ultrasound, you will be able to pick out any proximal dilatation if it is there. Plain CT scan of the KUB is the most common and the most specific investigation. It gives a very quick diagnosis as well as helps us to plan the surgery also. And RGP is retrograde pyelography. You generally do it during the surgery to see where the location of the stone is to plan the surgical procedure. Regards to medical management, there are multiple things, but I think from the surgical aspect of medical management, what we give sometimes is called hydrotherapy. It means We hydrate the patient with some IV fluids, give some painkillers, and alpha blockers help in relaxing the bladder neck so that patient, if it's a small stone, they pass the stones per urethral. Vaishali madam will tell us more in detail about this. In surgical management, multiple options, but not all options are available to us in pediatrics. Mainly URSL or cystolithotomy is what we prefer. PCNL is done in a very selective cases if there is a large stagon kind of calculus in the kidney. Lot of times we just do a digestant insertion, let the calculus come down, and then tackle the stone with a cystoscope. Open surgery in urinary stones is very limited role nowadays because most of these procedures can be done very well more effectively by endoscopy rather than open surgery. But then, especially in pediatrics, sometimes we have to resort to open surgery because things are just too small. Yeah, that's it from me. Thank you.
Thank you so much, Shalil. I invite Vaishali to say about medical management and the causes of these renal stones.
Thank you, ma'am. I think a lot has been covered, so there is very little left for me to cover. But let us go through it very fast since we are already a little late today.
Shalil, you'll have to stop sharing.
Yes, how do I think madam has already started.
Okay.
I think, yeah. So can you see the screen?
Yeah.
Ma'am,
No, not
please
now.
share your screen.
Okay.
Ma'am, Vaishali ma'am, you can share your screen now.
Yeah, I'm doing that. Can you see the screen now?
Yeah.
Yes, ma'am.
Okay, so basically, let us look at what are the risk factors. So any patient who is having a urinary tract malformation or repeated infections, children who have obesity or who have a problematic diet, we have already discussed this in detail about the high content of sodium or protein in the diet. Children who are preterm, who have been admitted to NICU and who have inadvertently, kind of received a lot of medications in an immature kidney when they have received these medications and they have had dehydration. These are the ones who are likely to form renal stones. Any patient who has a chronic bowel disease where there is a malabsorption is also highly likely to have a renal stone. Patients who are having neurological diseases because they are having reduced fluid intake, they are also the ones who are likely to develop renal stones. In addition to this, how do they present? In infants, when infants are presenting, the symptoms are very vague. They do not have any specific, they may just be irritable. And in older children, you can have abdominal pain or gross hematuria, sometimes microscopic hematuria, which you find because the child has complained of dysuria. Recurrent urinary tract infections, as we already said, and acute retention, the way has been seen in this child. This is, I think, just the second case that I have come across. The first one, also the bladder was not reaching the umbilicus, so it was not this bad. And it is mentioned in literature also that this kind of presentation is very, very rare. You usually get a history of a first degree relative affected in 20 to 75%. But then every time when a relative is affected, it need not be a genetic predisposition. It is likely to be either an environmental factor or it could be that the diet itself is defective in all of them. So what are the investigations? This has been covered. I will not go through the imaging ones. So in blood test, we do urea, we do creatinine, uric acid, and electrolytes, that is sodium, potassium, chloride. Then we also do calcium, phosphorus, magnesium, and vitamin D and PTH. Of course, PTH we do only if we are finding anything abnormal. The urine tests, previously we used to look for crystals in urine, but hardly anybody, even the medical colleges are not doing that. Urine routine microscopy, as we said, will show us microscopic hematuria and sometimes even calcium oxalate may be shown on the urine routine microscopy. We collect 24 hours in children who are able to, kind of collect 24 hours, the older ones. In infants, we do usually a spot test. And what do we look for? We look at calcium, oxalates, uric acid, citrate, protein, and electrolytes. When we are doing spot, we do spot of calcium and creatinine, oxalate and creatinine. We require calculation for that. And we have these standard reference values for each age group, and we compare it with these reference values and we decide whether there is anything abnormal or not. So then once you have done that, then patients are classified either into a uric acid abnormality or low citrate or hypercalciuria or hyperoxaluria. Of these multiple stones like this, and a renal function which is on the lower side, a creatinine which is high, repeated stone formations will usually go in favor of hyperoxaluria, which is little difficult to treat. And many a time these children present very late in life. In our nephrology group, we had one child which was being discussed where the child presented with with AKI on CKD and with a blood urea nitrogen of 300. And nobody has seen BUN of 300 till date. Then there are genetic factors also which can be causative. The common ones are dense disease, then hyperoxaluria, we already covered, cystinuria, and adenosine phosphoribosyl transferase deficiencies. So these are rare, and again, if there is family history and if there is recurrent formation and the child is, kind of presenting very early on in life, then we have to keep those in mind. Dr. Shalil has already covered the treatment. The medical expulsion therapy also he has covered. So for medical expulsion therapy, we require fluid to be given. So the fluid has to be 80 to 100 ml per kg, and it is quite difficult in smaller children. So you may require to admit a child. That particular stone, which was like 4 millimeter in the ureter and with proximal hydronephrosis in this child, could easily be, kind of pushed down with medical expulsion therapy. But this child was not willing to stay admitted, and probably that is why it took longer for him to really expel that. What we do is that when we are administering MET, we tell them to pass urine through a sieve, like a plastic sieve which we get on roadside. We ask them to buy that and make the child pass urine through the sieve. So in case the stone is expelled, then we can do a stone analysis, and that is more diagnostic. So I think with that, I will stop screen sharing. If there are any questions, then we can answer them.
I remember one more case. We had one child with a single stone, Vaishali. Do you remember? That child was admitted with pain, and that child, you gave a urethral dilator.
We use either a calcium channel blocker or we use alpha blocker like tamsulosin. Tamsulosin is preferred, and we also give a low dose steroid so that no stricture formation occurs when the stone is So it works. Not that it will work in every patient, but medical expulsion therapy does work in a small number of patients.
Yeah, and this patient it worked, and he had a single stone, and he had kept a sieve, and he got the stone and he kept it in a matchbox.
Yeah. And there was one more patient with Balaji Hospital where medical expulsion therapy worked. So there are a few where it does work.
That's an amazing teamwork, madam. Anjali, Dr. Vaishali, and Dr. Salil. Thank you so much. And now I request Dr. Archana Joshi, madam, to present her case, if we have time. Madam, you have to unmute. Unmute kara, madam.
Ma'am, next time घेऊन टाकू आपण. Can we need Dr. Tanu Singhal to discuss this case?
Yes.
And it's 5:51, so we won't be able to do justice to the case in 10 minutes.
Okay, madam. Okay.
And everybody is logging out. We were more than 40 people, and now we're only 30.
Still 30 are remaining to listen to you.
That itself really is commendable, ma'am. Nobody, other groups I know, having 30 also says a lot about.
She will give expert comment, but she's not around. So what do we do?
So you decide, madam, whether you want to present in next meeting. It's okay.
I think we'll do it in next meeting, and maybe we'll take it as the first case.
Yeah, first case. Yeah.
And I will ask Tanu what time she can join. She joined, but then she had to go back, it seems.
Yes.
She has seen such cases which we had sent to her for expert opinion. So she says she's seeing a lot of cases of such kind. So it would be good if she's around and she gives her expert comment.
Okay. Okay, madam. Yeah.
Thank you. Thank
And,
you.
with
Thank
this
you.
a knowledge feast we had today, I'm
Yeah.
really thankful to all of you who are there now and who were there to guide us. Dr. Leena, Dr. Hila, Dr. Vaishali, Dr. Amit Watkar sir, Dr. Anjali, Dr. Archana Joshi madam, Dr. Hemant Joshi, Dr. Samir Sheikh, Dr. Salil, and Dr. Anuradha Palwankar, Dr. Alka Badbade, Dr. Sylvia, so many are there. I'm
I
so
can see
happy and
Chitra also.
thankful. And
Dr.
Dr.
Chitra,
Chitra,
Shailesh,
Dr.
Vaibhavi.
Shailesh and Vaibhavi are there. And thank you so much for so much input from Shailesh in autism. We would like to have more sessions on autism at least. We will learn more from the expert. Yeah.
Jayashree, please tell us
So
about the workshop that is upcoming in April.
yeah, and it's a good news for all of us that Central IIP has given us diagnostic stewardship workshop on 14th April. It will be at Club 1 Virar and the timing is 8:30 to 2 p.m. So we please attend this. Please be there to represent our Palghar Academy of Pediatrics.
We'll be there.
Yeah, thank you so much.
Okay,
Thank
ma'am.
you very much, Jayashree and Wasim, for
Thank you, ma'am.
conducting this and moderating.
And thank
Thank
you,
you, ma'am.
Anuradha, for giving
Credit
us
points.
MMC points. Thank you, Dr. Vasim, for
Untiring work for the last 2 years.
Thank you,
Thank
ma'am.
you very much, Anuradha.
Thank you, madam.
Yeah.
Thank you.
Thank you. Thank you.